Thank you, Dr. Dev Pujari, and welcome to this joint webinar, which has been arranged jointly by the Neuroendoscopy Society of India and the WFNS. I would like to invite the first speaker of this program today, Dr. Karmarkar. Dr. Karmarkar is a consultant neurosurgeon and endoscopic skull base as well as neuroendoscopic surgeon at Bombay Hospital, Mumbai. Dr. Karmarkar, are you
Yes
connected? All right, please
Can I
share your
start
screen
sharing?
and please share your screen.
Thank you, Dr. Sankla and Dr. Dev Pujari, for the kind invitation for this. I think what we are going to go through is a brief, broad overview of something that all of us are familiar with, and just as a revision or as a reminder, if you may. But this would be sort of from the focus that the ventricular system is used as a conduit to reach our surgical target, or in some cases, as we will see today, is the target itself for surgical procedures. We are here as a subspecialty because of improvements in technology and, of course, in improvements in our understanding of the anatomy and pathology. So I thought this would be a small routine framework to base this sort of review on. But before we begin, a slightly philosophical question. Why should the ventricular system exist? We know the current description from the time of Vesalius and Willis. We know it's the cavity of the central neural, cavity of the neural tube. And we also know that a closed cavity and the periventricular region is a driver of brain growth and neuronal migration. The next thing that we know importantly have learned over time is that it is the area for production of CSF and the circulation of CSF. And most interestingly, it contributes to the formation of certain circumventricular organs. Of course, to a large extent, we are interested primarily in the pituitary gland and the pineal gland, but they originate from around the ventricular system. Coming back to the ontogeny of the ventricular system, we begin in the 4th week of life with 3 vesicles: the forebrain, midbrain, and the hindbrain. By the 5th week, we already have developed a telencephalon, a diencephalon, a mesencephalon, and the hindbrain expands to the metencephalon and the myelencephalon. These are the adult derivatives, and each of these adult derivatives has a cavity which we call the lateral ventricle, the 3rd ventricle, the aqueduct, and the 4th ventricle. An interesting paper that I found by O'Rahilly, published in 1990, describes in great detail all these stages that we have alluded to just now, based on the Carnegie stages of embryo. So, with further development and asymmetric growth of the prosencephalon and the rhombencephalon, you get your adult type or a developed type of ventricular system, which includes the lateral ventricle, the ventricle, the aqueduct of Sylvius, and of course the 4th ventricle. So, as far as the lateral ventricle goes, Professor Roten has very eloquently described or reminded us that it's a C-shaped cavity, and it's the epicenter is a thalamus around which the cavity is wrapped. And there's also a close relationship of the caudate nucleus and the internal capsule as well to the lateral ventricle. So the parts of the lateral ventricle, you have the frontal horn, which is the part anterior to the foramen of Monroe. These are the boundaries. Then you have the body, which actually begins at the posterior edge of the foramen of Monroe and goes back to the junction of the body and tail of the caudate nucleus. Now, within the ventricle, the caudate and the thalamus are separated by a striothalamic sulcus with the stria terminalis and the thalamostriate vein. The internal capsule genu is very close by over here, and is something we must take care of when we are entering into or navigating the lateral ventricle. Going further behind, we have the atrium and the occipital horn. This is a triangular with the apex in the occipital lobe. And of course, then the temporal horn, which extends from the atrium below uh, into the medial part of the temporal lobe and ends blindly behind the anterior wall of the, behind the amygdala actually. Now, the septum pellucidum is another structure which we should be aware of. Literally means translucent walls between the lateral ventricle. This is triangular with its base towards the corpus callosum. Inferiorly and posteriorly, it fuses with the fornix, fornacial columns, and anteriorly with the genu and the rostrum. This consists of two layers of gray and white matter, which usually fuse during fetal development. And if this space persists between them, then it is known as a cavum septum pellucidum. So coming to the next target on our passage from the lateral ventricles down is the foramen of Monroe. Name is credited to Alexander Monroe Secundus, who is also incidentally the propounder of the Monroe-Kelly doctrine. The normal foramen of Monroe is an oval cylinder which is flared at both ends, and the plane of this is oblique. So it slopes downwards from medial to lateral and from posterior to anterior. A good way of describing the axis would be it is in line with the perfectly placed EVD, and this underscores the need for placing our burr hole for entry with a rigid endoscope, especially for anterior third ventricular procedures. This paper incidentally shows the average area of a normal foramen of Monroe, which is around 5.23 millimeters square. Endoscopically, you see this picture of the foramen of a dilated foramen of Monroe. This is medial. If you see in the clock fashion, you have the choroid plexus, which is an identifier which usually leads up to 6 o'clock position. And this choroid plexus then continues on the roof of the third ventricle. At say 7 to 1 o'clock, you have the column of the fornix. Then laterally, you have the caudate nucleus and the thalamus, and the thalamostriate vein separating the two. Now, the internal capsule is in this region, so care needs to be taken, obviously not to damage the internal capsule, which can have disastrous consequences. This is a sort of inspection of the ventricular system in a 14-year-old with a cortigeminal cyst with hydrocephalus. So you can see in this patient, we have entered the right ventricle, and because of an absence of the septum pellucidum, you are able to see both the lateral ventricles. You can also see the columns of the fornix. On the right side, you can see the foramen of Monroe with the thalamostriate vein, and the foramen of Monroe, the choroid plexus ending at 6 o'clock, as we described earlier. Moving on from the lateral ventricle, we enter into the center of the brain, or the cavity of the diencephalon, which is the third ventricle. This has been an area of great surgical interest, with many approaches which have been described to the third ventricle in various methodologies. But endoscopically, I think I find it very useful to have this image in mind whenever we are navigating into the third ventricle, and to understand the boundaries of the third ventricle. You have the anterior commissure, the lamina terminalis, the optic recess, the infundibular recess, tuber cinereum, the mammillary bodies, posterior perforated substance, the aqueduct. Going behind, you have the pineal recess with the pineal gland, the suprapineal recess. And in the roof, you would have the internal cerebral veins. So this image is something that probably all of us need to keep in mind when we are dealing with this with anatomy or pathology in the ventricular system. This is a brief video to navigating us through the foramen of Monroe into the anterior third ventricle. These are the mammillary bodies and the area of the tuber cinereum, which is thinned out with the basilar artery and the PCA seen. Incidentally, this patient has a tumor sitting in the anterior lateral third ventricle. And this is again a view of the third ventricle in a previously shunted patient who came up for secondary ETV. The shunt was probably for aqueduct stenosis following post-hemorrhagic hydrocephalus. And you can see the staining in the ependyma, but you can see a panoramic view of the whole floor of the third ventricle. This is the area of the aqueduct. And as you go behind, you have the pineal recess, and beyond that would be the quadrigeminal plate or the quadrigeminal system. Moving on to the cavity of the mesencephalon, the aqueduct of Sylvius. Once you navigate through this, preferably with a flexible endoscope, you have the opening with its base corresponding to the posterior commissure. As you go in further, you have the rubral eminences, which are the protrusion of the red nuclei into the aqueduct. Then you have the first constriction, which corresponds to the superior colliculus, a dilatation, which is an ampulla, and the second constriction, which corresponds to the inferior colliculus, beyond which you enter into the fourth ventricle. Variations of the aqueduct abound, and these are some studies from literature which show the average diameter and dimensions of the aqueduct that can be ascertained. Moving on, we go on to the fourth ventricle. We usually don't see a clear picture of the rhomboid fossa like this picture. What we tend to see is something like this image. Access into the fourth ventricle would reach the foramen of Magendie or the Luschka with the choroid plexus that is seen. This interesting paper from Matula et al. In 1996 actually describes three approaches into the fourth ventricle. One is through the aqueduct of Sylvius. The second is through the foramen of Magendie. And the third, they actually described the access into the fourth ventricle via the foramen of Luschka. And they've done it using rigid endoscopes. So, but this was a partly cadaveric and partly clinical study. Moving on to the next component of the ventricular system, we have the choroid plexus, composed of mesodermal and ectodermal components. Embryologically, the fourth ventricular choroid plexus appears the first, and it is found in all parts of the ventricle except the aqueduct. In the ventricles, it enters into the through the choroidal fissure, which is an important landmark in neurosurgery. This is a C-shaped cleft extending from the foramen of Monroe to the inferior choroidal point behind the uncus and lateral to the geniculate body. The choroid plexus ends at the foramen of Monroe, like we have seen earlier. In the atrium and occipital horn, it forms a glomus and extends to the temporal horn and ends opposite the hippocampal head. The arteries supplying the choroid plexus would be anterior choroidal artery and posterior choroidal artery, and of course the branches of the AICA and PICA in the fourth ventricle. Now the fourth ventricular choroid plexus is described as having an inverted L-shaped structure, which protrudes through its openings, and there are two arms to this, or two limbs, the sagittal and the horizontal. The sagittal or the medial limb is found in the roof. It is near the midline, and again this has two parts, the rostral and caudal. And the horizontal or the transverse limbs arise from the rostral ends of the medial segment and extend out of the foramen of Luschka into the CP angle. So within the ventricular system, the primary arterial supply is from the choroidal arteries, anterior and posterior, and the AICA and PICA. Venous landmarks are several, and they are very important for us. You have the septal vein and thalamostriate veins, which we talked about earlier. The internal cerebral veins in the third ventricle roof, and of course, as you go out, you have the basal veins of Rosenthal and the vein of Galen. Coming to the applied anatomy, this is what some of our current reach with endoscopy today. Today's focus, of course, is on tumors and tumor-related neuroendoscopy. So I will leave it at that. Thank you, and I would appreciate comments or questions because anatomy is always a vast subject and there are many nuances and many layers to this. Thank you.
Thanks, Vikram. If there are any immediate comments from the panelists or rest of the faculty, please go ahead before we proceed to the next one. And I welcome Moody Qureshi, our co-moderator for this session. Welcome, Moody.
Thank you very much, Chandra. And I just got in when the anatomy was being described and very well articulated. Thank you very much for that educational talk. Thank you.
So any comments?
Vikram, sorry, just a brief question.
Yes, sir.
If you have this flexible endoscopy in doing some intraventricular assessment or intraventricular surgery, what more structures do you see which you couldn't see with the rigid endoscopy? Just briefly, please let us know.
I think the easiest would be the posterior third ventricular anatomy would be much clearer from standard Cocker's burr hole. And I think important application for a flexible endoscope would also be choroid plexus coagulation in conjunction with an ETV, as has been described recently, and there's been some resurgence and renewed interest in the topic. I think straight off, these would be important indications or applications for flexible endoscope.
Good, thanks.
Another thing probably maybe the very front, the optic races, the
lamina terminalis perforations also.
And the temporal horns, maybe.
Yes.
May I just ask a little bit of a technical question? ETV has kind of almost become synonymous with the floor of the third ventricle. And I think when we are indicating treatment for hydrocephalus, the world over, everyone seems to obviously concentrate on the tuber cinereum, entry into the third ventricle, look for the basilar, etc., etc. But there are fair instances, and particularly in our countries, where post-infectious hydrocephalus is a problem, and the floor may be thickened and may not be very clear. What would your approach in terms of anatomy be to go through the lamina terminalis? I mean, what are the key points? Obviously, with the foramen of Monroe there and a rigid endoscope, it becomes a challenge. But now with flexible endoscopy and the anatomy that you have very beautifully described, I think there needs to be, from our point of view, a shift in paradigm for the trainees and those who do this very often, that if you can't get into the floor of the third ventricle, look for these landmarks and go through the lamina terminalis, because we almost have created a mindset that if you can't do an ETV, then you got to go for a shunt. And perhaps there needs to be a review of that thinking and saying, if you can't get through the floor, then look for the lamina terminalis. These are the anatomical landmarks which you should become regularly familiar with, even when doing an ETV, so that in case you find that the floor is too fibrous, too thick, or not quite anatomically visible, and you're concerned about perhaps the basilar being too close to where you want to go, or for any reason are unable to, then don't just give up at that point. Look at these anatomical structures and try to get through the lamina terminalis, because essentially you want to create an opening for the CSF to drain out into the basal cisterns. So what are your thoughts on that one, and what is your recommendation or advice to those who do this as to what
Vikram can probably answer that, but I will ask Dr. Ortel, who's in fact written about it, to also comment on this.
So I don't have much experience with a flexible endoscope, especially for a lamina terminalis penetration. But I would the infundibular recess and the optic recess and go above that. And the end target would be visualization of the ACA complex. Just like at the end of an ETV, you have the basilar artery and its branches. That would be the end target above the optic recess. Having said that, my estimation is that if you have a scarred third ventricular floor post-inflammation and post maybe TBM, you're going to probably have the similar kind of inflammation in the lamina terminalis region as well, the so-called basal exudates, etc. Clinically, that still may be a challenging area. That was just a thought, but as Professor Ortel, he probably has more experience and maybe can give a different sort of perspective.
Can I make a comment?
Well, I can comment on this. I think lamina terminalis opening is really rarely indicated if you want to do an ETV and are not able to do it at the floor of the third ventricle, because even if you use the flexible, the stoma you create is usually quite small, and it's not that easy to create really a sufficient opening. And as Dr. Kamaka said, it's a problem when you have, what is the problem when you are not successfully doing an ETV at the floor? Usually it's membranes. It's usually not the distance between the basilar artery tip and the clivus, no, because all these challenges you can actually deal with. I think it's usually membranes, and then it's likely that you also have membranes at this lamina terminalis. So if you really think you could avoid a shunt, I personally would recommend to do rather a small supraorbital craniotomy keyhole approach and then do the lamina terminalis opening. I think this anterior subfrontal approach is much safer. You can create a much larger opening. You can resect all the membranes, and you preserve definitely the optic chiasm and the anterior complex. So if you think it's an indication, then I probably would talk to the patient and do a second procedure with a supraorbital approach for the lamina terminalis opening. It's very rare that we go through the lamina terminalis and with the flexible. Very rare. At less than one case a year.
Yeah, I totally agree with Ortel. The space is very limited compared to the other options we have. Having said that, I think when the floor is tough and we are not able to negotiate, first option is to use other techniques where you can go to the dorsum sellae and make a way through the floor. And if it is completely not possible, the second option is to explore membrane, or probably you can get into probably that is the second option we can do that. Third, when the floor is scarred, not necessarily that lamina terminalis is also will be scarred. Most of the times it will be transparent, provided the third ventricle is well dilated. Otherwise, the space limited between the supraoptic recess and the infundibular recess is very narrow, with the anterior communicating artery and its branches right there. So I think this is the option. If you are comfortable and there is enough dilatation of the anterior wall of the third ventricle, then you can certainly make an attempt with the opening from inside. Otherwise, as Ortel suggested, it's better to go back and do a microscopic method.
Fair enough. My only point being made was that if one doesn't get familiar with the territory and you're seeing it for the first time, you'll always be a bit cautious about going through there. So before one goes, so it's not either, my point was that it's not either ETV or shunt. There needs to be a discussion. And if one doesn't become familiar with that territory, as has been described beautifully through the anatomy, then you're never going to gain the experience. Because if you don't look for it, you're never going to know where it is. You're never going to try it. So I'm just trying to kind of not create a controversy here, but just beginning to give a point that perhaps one should look at it. And if you cannot, then do the other options. But absolutely right, it's not something that we do regularly, and we don't do it because it's not there for us to do easily. It always provides a bit of a challenge. Just a point to be thought about, and that was the reason I brought it up. Thanks, Hokip. Thank you for sharing your experience, and always good to see you.
Posterior wall,
Dr. Sankla?
interestingly, sometimes the posterior wall, the third ventricle also can be very thin and dilated, in one of those arachnoid cysts what we had. And all that we need to do is just open that wall and it became a ventriculostomy posteriorly. I mean, I don't know whether it can be a procedure, but certainly, I mean, these are the options we have with the flexible endoscope.
Thanks,
Sankla, Dr. Ortil has to go away. Can we have his talk first, you think?
yeah, I think, yes, I think let him have this.
So maybe, Joachim, if you could do your talk first.
Yes, I hope my audio is good, and it's a pleasure for me to be part of this webinar. So you see my slides?
Yeah.
Wait, you see my slides? Is it working?
It's working.
So thank you for the invitation. The topic is endoscopic CUSA for intraventricular tumors. So it's a little bit ahead of the schedule because I think there are 2 or 3 more presentations on how to deal endoscopically with the intraventricular lesions. But, well, I have to disclose, I used to act as a consultant. Now I don't have a consultant contract anymore for Storz company related to this because I have no consultant contract with the company who provided this CUSA. So this is where I'm from. Most of you know this, and this is our department. When we think about indication for endoscopy in tumors, we usually think about smaller craniotomy, as I discussed just with the laminar terminalis approach. Then we use reduction of the surgical trauma. Intraventricular surgery, usually we think about reduction of the surgical trauma because particularly the third ventricle is very difficult to access. So there are a lot of different indications for endoscopy in tumors. Well, most of the applications we do actually, it's an endocystic approach, cranial approach, and endonasal approach. But transventricular surgery, of course, it's a endoscopic technique through the worksheet. And the ideal indication is a tumor procedure in combination with restoration of CSF circulation. Well, what is the indication? Well, basically, any lesion adjacent or within the ventricular system is a potential candidate for an endoscopic procedure, tumor biopsy, cyst fenestration, or tumor resection. Well, actually, it's very difficult to select the ideal candidate. So sometimes you switch from a shear endoscopic technique to a microsurgical procedure with an endoscopic assistant. And sometimes you think, well, you approach a lesion microsurgically, and then you think, well, I could have done this in a shear endoscopic technique. So it's difficult to select the ideal candidate. They are either too large, too vascularized, too firm, too time-consuming to resect. So it's, there's no real criteria where you can select one candidate for ideally for endoscopy or for microsurgery. Well, our general results, we have done now a little bit more than 150 shear endoscopic intraventricular tumors. It's in biopsy in tumors. It's the diagnostic yield so far is 100%. Bleeding in tumor procedures is a frequent problem, particularly when you think about gliomas or you consider colloid cyst to be an intraventricular lesion. Those are frequently, you see frequently a problem with the resection. So far, we had no emergency stopping, but we had switches to the microscope in 3%, so it means like 5 to 6 cases. And best results is in combination with CSF circulation restoration because you have enough space to maneuver the endoscope. At this thumb rule, we use solid tumors larger than 2 centimeters are not suitable candidates for a tumor resection. And this is actually where it comes to the attention that we maybe when we have additional surgical techniques that we can widen our indication for a shear endoscopic technique. So ultrasonic aspirator is such a technique, and I use it in microsurgery basically with all gliomas, all intrinsic brain tumors. But in the endoscope, it's rather challenging. So in the beginning, when we developed this instrument, we thought about, can we develop a handpiece which fulfills the requirements for a minimally invasive and endoscopic procedure? Does such a tool really improve the neurosurgical options in these indications? So this is already more than 10 years ago. We had developed a prototype with a serving company, which is in North Germany. And then we did CUSA ultrasonic resection, first in pig brain underwater, so to simulate like an intraventricular procedure. And then we actually applied the endoscopic CUSA in 3 hematomas and 3 adenomas. And this was published in 2008 in the Journal of Neurosurgery. It turns out that with the current status, this is a Sonocar 300, you can adjust the frequency range from 20 to 80 and the vacuum suction from 0 to 0.9 bar. With this, you can use the handpiece underwater and under air. So both options are possible. The handpiece fits, to my knowledge, still only the GARP endoscope. I'm not aware of any other endoscope which really fits. There is the development of a new CUSA, but I have not used it so far, which should fit the other endoscopes like the Lotta endoscope. All procedures we performed were done with a rigid 0 degrees Rotlands opkits and standard operating sheet and the standard neuroendoscopic equipment. Oops. So we have done only 36 procedures so far with a shear endoscopic technique and with intraventricular tumors and CUSA. So there were 8 huge pituitary macroadenomas extending into the ventricles, 3 intraventricular, 4 craniopharyngiomas. So I think it's a very good indication. 4 subepidermomas, which also, in my opinion, is a very good indication, and 1 cyst and 4 colloid cysts, which I think is also a very good indication. So everything which is rather non-vascularized and it's in the ventricular system with a huge amount, a large size, is a good indication. So this is how we use it. Let me see if this runs. This is the technique. So basically you push it under direct visual control through the endoscopic sheet. And then to adjust, you have to maneuver the whole endoscopic sheet as in any other endoscopic procedure. So it's rather challenging when you have a big tumor in the third ventricle. You have always the risk to harm the fornix and the border of the foramen of Monroe. So this is an ideal indication. You see here, this is one of the subepidermomas under air. So just after, in the dry field technique, after sucking out the CSF, you just use the CUSA, and this is really done in a couple of minutes. You can take out these subepidermomas because they are so frequently non-vascularized. This is another indication, another example. So underwater, so here we use the CUSA to resect membranes in an isolated cyst. You see this patient after cystoscopy has an isolated lateral ventricle, and then you see when we go in with the endoscope, we use navigation, trigonal approach, and now you're within the ventricle, the isolated ventricle. You see these membranes which block the CSF circulation from the lateral ventricle to the body of the lateral ventricle and the anterior horn and the foramen of Monroe. And then this is usually done with navigation. You just determine the ideal position for the stoma, and then we do the stoma with a bipolar or with a laser. You can use either way, I think. Important is to do the opening. Let me forward a little bit.
Then we start to resect, and you see here when you started to use just the CUSA to take out the membranes. And these non-vascularized tissue, to take this out, this is, in my opinion, the ideal indication for the CUSA. This really gives you a much faster resection of the tissue. Here, this is now the ultrasonic aspirator. And then even underwater, so underwater, you see here clearly it's the cyst is still filled with CSF. You can use the CUSA to resect the membranes. Sometimes you have to you face a little bit bleeding, but it's not that frequent. You see here, and use irrigation a little bit. You can continue with the aspiration. And then here, this is the end result. You see the communication with the ventricle. So in our hands, the ultrasonic aspirator is highly efficient in neuroendoscopic procedures. The problem is the selection of candidates. The handpiece is well designed, and there was no problem with handling. We had sometimes significant problems with the malfunction of the handpiece. So each time the isolation is not optimum, then it gives an error and then it doesn't work. But right now, for the last maybe 2 years, somehow the handpiece is working very well. So we have 2 handpieces for the endoscopic application. And for the last 2 years, we had no problems. But before, we had minimum 8 to 9 different handpieces, which had every other case a malfunction. And the amplitude, let me go back. The amplitude, I said, is set from 20 to 100%. And aspiration in all cases applied possible. So far, no complications applied with the CUSA. I think the ideal indication is soft tissue and hematoma. Firmer tissue is more difficult. I have also a video on meningiomas. And meningiomas, where you think that the standard CUSA is not working appropriately, this small CUSA will not work at all. So it's rather less efficient than the standard CUSA handpiece for microsurgery. And well, in my opinion, the intraventricular aspiration is easier when you use the dry field technique. So you suck out all the tissue, because then you don't have the problem with the blurred vision and the bleeding when you suck out the tumor. So I think the handpiece provides another option in neuroendoscopic procedures. It potentially enlarges the indications, but I think it's not a good tool for the beginner. So I think you need some experience with endoscopy. And I cordially invite you to our 10th anniversary Neuroendoscopy Week, and I still hope that it's going to be a success, although these difficult times. And we have also the World Meeting of the ISMIS, the International Society of Minimally Invasive Spine Surgery, after the Neuroendoscopy Week. Thank you for listening. Sorry for being so interruptive, but I really have to leave soon for the airport. Thank you.
Thanks, Professor Ortel. Any questions before he leaves for the airport?
Okay. First and foremost, I'd like to thank you for coming to Mombasa and giving Ben Okanga a hand. I think that was very generous of your team to come in time such as this. But thank you very much. It was a pleasure to learn that you were able to help out in Mombasa. Thank you.
No problem, Uri. It's a pleasure.
Yeah. And secondly, from nice, thank you. From a point of view, from what you describe, it's obviously valuable in the softer tumors and not so valuable in the firmer tumors. So how would you compare just using in the softer tumors just an ordinary suction and through the endoscope with those finer suction suckers. Would there be a significant difference?
Good point. Very good point. So I think particularly for the colloid cyst, for example, you know, the colloid cyst, the fluid, this sticky fluid filled colloid cyst, you can use just a nasogastric tube. It's the same. It's no difference. But for the craniopharyngioma, you know, with these rather firm, this fibrous tissue, and the colloid cyst, which is rather firm, it's not fluid. For those, I think the ultrasonic aspirator is better.
Okay, great, thanks. And for the standard ependymomas, would there be a significant difference?
Well, ependymomas, I think the standard ependymomas probably, and gliomas, I don't like very much when they are larger because you have a problem with bleeding. So I mean, we have a couple of gliomas, but they are really, in general, they are small. So then you basically, if you have a glioma like 5 millimeters, 6 millimeters in diameter, ideal indication for the CUSA. If I have a glioma 3-4 centimeters in diameter, you have a problem with bleeding. And the same with the ependymoma, with the neurocytoma, horrible. You cannot use it. It's bleeding everywhere. So then you have to use the dry field technique, and then sometimes you can use the CUSA and you can proceed with endoscopy. But frequently in these cases, I rather do microsurgery, to be honest. And then it's not required to use the ultrasonic aspirator through the tube because you don't need it. If you have a larger microsurgical approach, you need the endoscope just to look around the corner and everything. But taking out the tumor, in the intraventricular tumor, you can usually use the bipolar.
Joachim, I think if it is possible for you, if it is possible for you, please join when Sharath is talking. He is talking about removal of intraventricular large tumors with endoscopy, and he has developed his own technique. So it would be, if you can manage, please join later. But thank you very much for your appearance. After Manas's comment, we move to the next one, Suresh.
Yeah. I know. So what is the urge of this handpiece, and can it develop with a coagulating type, both suction and coagulation? Is it possible to develop a handpiece which can both coagulate as well as aspirate? The total.
Well, so far it's not on the market. I cannot say anything. So we had before. Some of you might remember a very nice bipolar forceps for the endoscope, which actually is taken from the market because it was so fragile that frequently you had problems that the branches were left inside the ventricles because it broke during the procedure. So I doubt that this is possible. It's obviously, to develop this handpiece is so challenging. So because they really, it's obviously it's very difficult to develop a CUSA with that slim for the company, because there's also a very nice the original CUSA. They have also, I talk to them frequently, they have no option to develop an endoscopic handpiece.
Atul also has raised his hand. So
can I ask one question?
Venkat.
Yeah, Vortel. I think all avascular tumors, probably this is very ideal to use, including epidermoids probably. How do you decide preoperatively? Is there any way other than the size of the tumor? How do you assess bleeding, whether to use CUSA or not to use CUSA? You initially operate and then take a call, or you...
If it's very, very high vascularized, so you see the vessels, or you see it's highly enhancing lesion, then it's unlikely that it's going to be easy. Okay, so if you have a suspicion for a subependyma, I think it's good. If you have a suspicion for colloid cyst or craniopharyngioma, is good. Adenoma, ideal candidate. Okay, then it's good. But if you see that it's rather firm, it's rather fibrous, well, it's always the same thing. I don't think that it's not mandatory to do it endoscopically. I think if it's safer and I feel more comfortable, I would just do it microsurgically, and then at the end use the 30-degree scope to look around and make sure that everything is taken out. You know, it's not that I will not give a whole day of surgery just to resect a lesion 3 centimeters in diameter when it takes me 1 hour with microsurgical technique without any negative side effects for the patient. So it's always, you know, you have to make up your mind what is the goal of the procedure and what's the effort I need, if is it cost efficient or not. Cost meaning not only money, meaning also my time, surgical risk, everything, you know.
Thank you. Thank you.
Is Professor Goel around?
Yeah.
Yes.
So that
please.
was a wonderful presentation, and the use of QSA and endoscope and all these things. I am not very familiar. I have not means I don't know. I don't use these things, but it is interesting to see and interesting to hear. And you have developed such a huge experience of 150 cases using endoscope and intraventricular tumor. And I congratulate you for your work and for your presentation.
Thank you, Atul. Very kind of you.
Thank you.
Just a question, okay. Is there any role for putting a separate port and then be able to use a larger CUSA and then view the so basically, through a smaller opening or a larger, not a burr hole, but a smaller craniotomy, putting in a separate, under neuronavigation, a separate port through which a larger CUSA can go, and then viewing it through the endoscope. I'm just thinking aloud.
We have a talk on biportal approach, Moody, coming later.
Right.
Unfortunately, Albert Sufia now is not going to join us, but he has sent his lecture. So we'll have that after Sergio's lecture. Suresh, please invite.
So I will keep quiet.
Thank you, Joachim. I think we move on to the next talk, and that is Professor Sergio Cavallero. I think everybody knows Professor Cavallero. He is one of the leaders, world leaders in neuroendoscopy. He is from Sao Paulo, Brazil, and he is going to talk on the experience with intraventricular endoscopic surgery for intraventricular tumor. Professor Cavallero, please.
Okay, thank you, Suresh. Thank you, Sandra. Could you see my screen?
Yes, we can. Please go ahead.
Okay. So today I'm going to share our experience in intraventricular tumor. I use a lot of CUSA during my procedures. I have a little bit different from Professor Ortel, but let's go to show. But in my opinion, the dreaming of neuroendoscopy is to try to completely remove the intraventricular tumor and restore the CSF circulation, just to do a borehole. Of course, all the time, and need to go to the intraventricular cavity, you need to pass through normal structure. So the strategy to arrive in the ventricular should be very careful studied before to go it. So, of course, if the intraventricular cavity is small, you can use 2 kinds of neuronavigation, optic or magnetic. Normally, in small children, I prefer the magnetic navigation. And when you can do to remove the intraventricular, you can use different approaches. The pure neuroendoscopy, it was our dreaming. The assisted neuroendoscopy, when you put a tube and with a normal instrument, you can remove the tumor, do a biopsy or inspection. So you can use each kind of the procedure. So what is the criteria in the literature for intraventricular endoscopic tumor resection? Should be a hydrocephalus, no calcification, no infiltration surrounding, soft tissue, cystic lesion, and the maximum tumor dimension less than 2 centimeters. It's not true, but it's the literature. So what about the kind of the tumor? You have the intrinsic tumors, derivated from the choroid plexus, papilloma, carcinoma, sometimes intraventricular meningioma, or derivated from the ependymal, the subependymal gigant cell astrocytoma. Look at that choroid plexus papilloma in the third ventricle. I am in completely agree with Professor Ortel. You need to do the surgery. Open surgery, you quickly remove some kind of tumor. But sometimes you have this tumor located in the very difficult area, a very dominant left side in the ventricular carrefour. In that situation, you can try to put the endoscopy. So, because you cannot open the left system. So, as you can see with neuronavigation, you arrive in this place, not to touch direct the tumor. But today, when you see the tumor with coagulation, you can shrink the tumor and try to complete resection of this lesion. And you can see here the pre and the post-operative. 16 years later, you have some scar in the ventricular cavity not grow. So you can remove all the choroid plexus papilloma by endoscopy. But look at this case, it's a large tumor. Again, the ventricular carrefour. In that situation, you can use the combined endoscopy. You can use an assisted endoscopy to try to completely remove this lesion. Some intraventricular tumor derived from the ependymoma is the SIGA, is the Bourneville diseases. You can vaporize that with a VersaPoint machine. You can inside the tumor, vaporize this lesion, then follow up by septoscopy to control this kind of the lesion. Of course, you can use everolimus, and you beginning to use everolimus in the prenatal period to stop the growth of this kind of the tumor. Some kind of neurocytomas, you can again to coagulate before this tumor is very vascularization. You need to remove all the vascularization. Then with CUSA, you can try to complete resection of this lesion pre and post-operatively. But the cavity more important for us, I think, is the third ventricle. The third ventricle, you have a door, it is the Monroe foramen. You have your empathy, is the SDT region, is the silvioacqueduct, and you have several regions of the third ventricle. The tail of the third ventricle is the formed by fornix, stella choroidea, and the internal cerebral vein. The example of this kind of tumor is the colloid cyst. It's easy to remove, as you can see here. Coagulate the capsule, remove the tumor. Sometimes you have a bulge, and sometimes you cannot go into the Monroe foramen. You can open the ependymoma, so then you open the capsule of the tumor using CUSA or aspiration. With simple aspiration, you can completely aspirate the tumor, coagulate the capsule, and sometimes you can remove all the capsule. Sometimes forbidden, you need just to coagulation, and here, and 6 years post-operative. Look, there is a small piece of the tumor not growing. It's possible to left inside. The anterior wall of the third ventricular is from the Monroe to the optic chiasma. The example most frequent is the chiasma glioma. So using the potential evocate like that, you can remove a part of this tumor, as you can see here. You don't need to completely remove it. Then you can follow up by chemotherapy. So when you have the aspect of the intraventricular tumor in the literature to remove it. So sometimes you have a big tumor, not hydrocephalus, not soft tissue. So in that situation, you can use CUSA, as Ortel showed. It's this machine. It looks like a gun. It's a gun to destroy this tumor like that. So how can I use it? Dr. Ortel showed us. You can do unburrowing, put the gap endoscopic. It's mandatory to use the gap. So I love this machine. I love that machine. When we discuss with the soaring company to try to use that. But look, for the craniopharyngioma, I think is the best situation for that. So, and look, and look at this kind of tumor. It's an astrocytoma. And look at this Monroe foramen dilatation. It's the third ventricle astrocytoma, a PC4 pathology. Then you inside the ultrasonic device. And with this machine, it's possible to completely aspirate this tumor, not bleeding a lot. During the situation, you put the irrigation, and look, you can see the perfect difference between the ependymoma and the tumor, like that. So you can completely remove this astrocytoma without bleeding, which damage a lot the fornix, and now after almost a complete resection of the lesion. So the pre and the post-operatively. So, and the floor of the third ventricle is from the optic chiasma to the aqueduct. You have several kinds of the tumor, supracellular cyst, supracellular tumor, craniopharyngioma, germinomas, armartomas, brainstem tumor. In that situation, the most frequent is the craniopharyngioma, and the craniopharyngiomas, when inside to their third ventricle, I think the best treatment should be with ultrasonic device, and here after complete resection of the tumor. The other example is the amartomas that produce elastic seizures like that. Using this kind of CUSA, it's possible to completely remove this lesion. And look at the Monroe foramen, the bulge of the hypothalamus. Again, you open the ependymoma, then with ultrasonic device, you try to completely remove. It's soft tissue, but you cannot arrive to remove it only by aspiration. When you put the ultrasonic device, it's possible to remove it. All the time, I use a lot of irrigation to give a good visualization of the lesion. And now, after complete the connection of the hypothalamus, and the patient not present anymore the elastic seizures. So now, after complete resection of this hypothalamic amartoma, and the patient in a good condition, and here the post-operatively. Sometimes you have the brainstem tumor grow through the third ventricle. It should be a good approach for neuroendoscopy like that. Look at the tumor blocking the aqueduct. So it's an old case, but it's a good example. The patient was performed a third ventriculostomy in another center. Then you arrive. In that situation that you have ultrasonic aspiration, I try to remove this lesion by force, piece by piece. It's a long time, but then it was possible to complete the resection of the lesion, restoration of the CSF circulation, and see the aqueduct, and here after complete resection of this brainstem tumor, exophytic to the mesencephalon, and the pre and post-operatively. So in the posterior wall, it's from the suprapineal recess to the aqueduct. The most important is the pineal gland. In that situation, it's very good to do a biopsy, not to remove the tumor. We do a biopsy on the serum marker is negative. All the time you do a biopsy like that. So, and they use the no-two approach. I put the entry point in the middle. It's possible to do a third ventriculostomy and remove a piece of the tumor. Like in this example, looks a preview third ventriculostomy, interthalamic adherence, and the tumor with a small calcification. You don't need the pathologist. The majority of the case, it's a germinoma. You do a biopsy, and it was a germinoma after chemo and radiotherapy. It's some mistake in the literature. I think sometimes when you have a bifocal tumor, all people say it is a germinoma, you don't need a biopsy, but look at this case, 2 years old, it should be not a germinoma. I do a biopsy, it was an embryonic tumor. So when it's possible, do a biopsy and restore the CSF situation. In the lateral wall, we will have the thalamus, some thalamic lesion with cystic component. It's possible to remove the cystic component and to remove part of this tumor by endoscopy. What about the aqueduct on the fourth ventricle? I think it's dangerous region not to go to the fourth ventricles to the aqueduct. It's my series. It's before 21 when you don't have a CUSA. So, and now after you beginning to use a CUSA, look in the past, you can produce a total resection only 30% of the patient. It's a new series. With use a CUSA, you can arrive to remove most the majority, most the 70%. It's possible to complete the resection of this lesion. So, in my opinion, we have made a lot of progress in neuroendoscopy approach, but you are still far from the ideal to make it our dream to complete resection of the tumor using only a borehole. So thank you very much for your invitation.
Thank you very much, Professor Cavallero, for this excellent demonstration of surgery for the intraventricular tumor. And I would now invite our panelists and the fellow speakers to really ask if there is any question to Professor Cavallero. Moody, would you like to
Sergio,
make any comments?
Very impressive talk, very beautiful videos. How do you decide these brainstem tumors, for example, brainstem or thalamic or subventricular tumors? When do you stop the resection through the endoscopy? You know, because sometimes you will have landmarks here. In your video, I can see that you were stopped once you saw the aqueduct level. And probably in other locations, how do you decide that?
Oh, when tumor, when you see the MRI, it should be not very hard tissue, sometimes soft tissue. And I use the same technique at Ortel. If it's bleeding, you remove the CSF and begin to work in the air. And it's easy to change again. If you cannot arrive to remove only by pure endoscopy, you transform in an assisted endoscopy, put a tube, and use all the instruments. So all the time in young patients, in left side tumor, I try to use the pure endoscopy. If it's not possible, I change it. If I wait 1 hour and see it's bleeding, it's hard, I move immediately. I not spend 8 hours to change it. If you're 1 hour, an hour and a half, you need to move it, you can move it. All the parents should explain what's happened. If you are going to change the approach, they have the consent before the parents. But all the time you go far. It's real, it's not for the beginning. The assistant, it's very important to close the aspiration, because sometimes you are near the choroid plexus and the assistant close the aspiration to not aspirate the choroid plexus, but it's possible to use in more decay. Sometimes after total coagulation of the tumor, it's become a hard tissue, you can put the aspirate and remove this post-coagulated tissue. So,
my second question is even to Dr. Ortel. When you are doing endoscopic resection of the tumors, especially paraventricular or subventricular, you will go by the differentiation of the tissue and you will be removing as long as you are comfortable with the surgery, or your aim is only to just get subtotal resection or come out?
I try to, in my opinion, you need to, in children, you need to remove all the tumor. All the time, I try to remove all the time, all the tumor. But sometimes you don't have a differentiation between the color or something like that, or the navigation, because when you go to endoscopy, the navigation disappears after you go in the ventricular because you have the shift. So, and you stop and don't have a more difference. But with endoscopy, sometimes it's better to see as the microscope. Sometimes this differentiation with endoscopy, it's better by as in comparison with the microscope. So I try to completely remove the tumor. So because you have a long time of the children, I do 100% of the patients are children for me. I think it's a little bit if you put in a glioblastoma. So if you try to put in a glioblastoma with endoscopy, it's not necessary to completely remove it. But if you completely remove, the result should be better. Put in mind, go the surgery to total resection of the tumor.
One question to you,
What's
Professor.
your policy?
And to,
You do the same thing?
Sorry?
sorry, Venkat.
You also follow this. Hotel, you also follow the same policy, or you?
Well, with a complete resection, I think it depends a little bit on the if it makes sense. I mean, as Sergio said, if you have a glioblastoma and it's unlikely that there's a high risk to take it out, probably you would not proceed. But one point we have not made very clear, in my opinion, is the big advantage of the CUSA is in the glial tumors, that you can better distinguish from the brain, the tumor and the brain tissue border. It's very easy to find the ideal layer with the CUSA. And this is also possible with the CUSA, with the endoscopic CUSA. It's not different from the microscopic CUSA. So this is a particular advantage of the CUSA. And then the advantage of the endoscope is that it's the high magnification. So the combination of the ultrasonic endoscopic CUSA is you have the very high magnification of the tissue, of the image, and the distinction between good and bad. So I think I agree that you can sometimes really much better see the border between tumor and brain using the endoscopic CUSA, even better than with the microscopic CUSA.
Do you use any fluorescein?
I think this is a very important aspect.
Yeah.
What do you think, Sergio?
Thank you.
Yes, I mean, I agree with you. It's perfect. With the CUSA, it's perfect. I should you improve more this machine, because for me it's the fantastic machine. Thank you for this invention. For me, I love this machine. I love.
Sergio, do you use any type of fluorescence, intratumoral fluorescence, to look at the, to get the gross total resections? Fluorescence 5LA or any of those fluorescent techniques you use with endoscopy combined? No?
No, I don't use this.
Okay.
There were two prototypes with the endoscope. The problem was that it was not small enough to fit the endoscopic sheet. So the prototype I used was about, at the tip, about 5.6 millimeters. So you could not bring it through the sheet. You have to use it like a port. And it worked very, very good. But in general, when you have a glial tumor, you can either distinguish identify the tumor tissue, or if you do not, then usually the glioma is so big that you don't really need an endoscopic approach. We have done very little, and at the end, we have not further proceed with this development.
Okay, just a question.
Okay, I have to go. Thank you for inviting me. Okay.
Absolutely. Thank you very much for your presence and your participation. Thank you very much. And have a good time and safe journey. Sergio, there's one question that's related to the craniopharyngiomas. The preoperative imaging has shown that the tumor is rather firm and there's calcification, and majority of it is in intraventricular. Some part of it is in the outside ventricle also, and there is expected some adhesions all around. Still, you would go endoscopically, or in those cases, you would rather go by an open approach?
No. When you have intraventricular tumor, because I think the craniopharyngioma said for you what kind of way he would like to go out or not. So craniopharyngioma is a really challenge. If they grow to the pituitary gland, you can go through nose intraventricular. But intrinsic to the third ventricle with calcification, I think the CUSA is fantastic, because when you go in the cyst, you remove the cyst, the tumor shrink, you can see the wall of the third ventricle, so it's left the calcification. In that situation, I put the CUSA in high potential and not move the CUSA. Stay there, and they try to break these stones, and you try to remove grand part of the tumor. Sometimes when you go to the nose and the tumor grow to the lateral ventricle, I use both combination, to the nose or the intraventricular, and you see a small piece of the craniopharyngiomas. So, and because sometimes when you left in place some part of the stone, the tumor will grow again. So you need to try to remove it completely. But sometimes it's very difficult. Huh?
Thank you. Thank you very much.
May I ask a question?
Moody, yes, please go ahead.
Sergio, thank you. That was an excellent exposition of the various tumors that you took out through the endoscope. And you showed a case, however, with, and you mentioned as well, the damage to the fornix. And I wonder, in some of those tumors, the large ones, and particularly the ones that you have described at the base, you're not actually able to see what's happening to the fornix. And I wonder whether you've evaluated either psychometrically or grossly during the end, how often the fornix may get damaged, and therefore would it be then justified because of the numbers that you see using a microsurgical approach? But I think because you've had a huge number, you might want to comment on that. Thank you.
I think, thank you, Mohammed, for this question. I think the fornix is very important structure. You need to protect the fornix sometimes. So in the third ventricle, when you go from the lateral ventricle to the third ventricle, you have some structures you need to protect. And then now I can change a little bit. If you see the literature, you can cut one side of the fornix without any problems. It's right. Other thing I try, you can coagulate the thalamus straight vein. Sometimes you can't coagulate, because if you coagulate the thalamus straight vein, you have a large corridor to the third ventricle. But I never coagulated the thalamus straight. But nowadays, I try to coagulate the septal vein. And sometimes I prefer to go to the choroidal approach than to damage fornix. So, but sometimes you don't have a choice. Sometimes you need to damage fornix. I try to protect all the time. I have one case in the end of the surgery, the fornix, it was completely destroyed and the patient have anything.
Is it because you're going, is there a difference whether you're going the dominant side? If the tumor is more on the dominant side, would you still go for the fornix, or would you go for the fornix if the tumor is more on the non-dominant side, and perhaps then alter the approach rather than go from the traditional right, the Foramen of Monroe, approach it from the left? Would you make a distinction if you think you might need to take the fornix?
No. In our results, there is no domination. I don't think the fornix. I think the fornix is very important, both sides. I don't do any dominance. I never cut the fornix with my. It's not volunteer. If I cut the fornix, it's something wrong. It's some disaster. But you don't have large problems. I saw some neurosurgeon from Australia. I follow this neurosurgeon. Sometimes you see the videos, the fornix is completely destroyed. I said, not right. Sometimes I see the people and see some third ventriculostomy. The people destroy the fornix for a third ventriculostomy. But I'd like to say just one thing that I begin to do. When you see the class about the anatomy, and the people say you need to do a translaminar terminalis approach. When you have a large membranes, I left a catheter. I put a catheter through the tuber scenario until to the bulb. I put a catheter and the patient, it's forbidden to put the shunt because other problems, the endoscopy should work. I put just a catheter from the lateral ventricle to the tuber scenario until to the bulb. And I left it.
And you anchor it with a reservoir, or you anchor it with...
No. I never put a reservoir. I hate a reservoir.
But you anchor it with something because it might just go...
Yes. I have a good cases with that. Some small patients have enterocolitis, a desiccation of both femoral prematures, but the endoscopy need to work. You don't have opportunity to put a shunt. Try to put an stent in the tuber scenario. It's work.
Okay. And you anchor it where? Yeah. You anchor it to the galea, or?
No, I fix in the dura. Yeah, I put a small stitcher, not very attached, a little bit flow, so go in the subarachnoid space and put this and the left this catheter. It's just to comment the previous presentation. So thanks so much for this invitation. I'd like to be in India with you. I love to go in India sometimes in the next year. I think it should be good. Okay.
Should be good. Thank you. Thank you very much, Professor Cavallero. And I think we will have more discussions towards the end of all presentations. Right now, we move on to the next talk, which will be by Professor Yadav. Professor Yadav is Chief of Neurosurgery and Director of Neurosciences at NSCB Medical College at Jabalpur, India. Dr. Yadav's contributions to the development of neuroendoscopy in India are great. He is also a former president of the Neuroendoscopy Society of India. Professor Yadav is going to talk about the tubular retractor for the intraventricular tumor surgery. Professor Yadav, please.
Thank you, sir. Is it, I'm audible and the slide is also seen?
Yes, perfect. Perfect. Please go ahead.
Thank you, sir. Thank you. So I'll be talking about the tubular retractor in intraventricular tumor. I'll be talking about the tubular retractor which we devised long back, and its use in intraventricular tumor. This presentation is divided into two parts. One is the various approaches which we use for various ventricular lesions, and second is about the tubular retractor use in intraventricular tumor surgery and how it helped. So for I think lateral ventricular tumor, frontal horn and anterior half of the body, we use frontal approach. And for, the posterior part of the body of the lateral ventricle, atrium and the occipital horn, it is the superior parietal lobule. For third ventricle, depending upon the location of tumor, it could be frontal, just in front of coronal suture, or more anteriorly if the lesion is much more posteriorly in the third ventricle. If there is an extension of the lesion in the pineal region and also encroaching the posterior part of the third ventricle, then we can go endoscopic infratentorial supracerebellar approach. Regarding the fourth ventricle tumor, if the aqueduct is dilated, then one can use flexible scope, but it is difficult except in cystic lesion and when the aqueduct is dilated. But one can also have a direct approach, transcortical or transcerebellar approach, when there is a large tumor, which we have used in some patients. So this also can be done endoscopically using a tubular retractor. Now, regarding the endoscopy, see, the beginner may get confused because most of us, sometimes we talk about that the lesion less than 2 centimeters should not be approached by endoscopy. It is true, but it is limited only when you use channel endoscopic surgery. That means when you are passing instrument through the working channel. So there is a channel endoscopy and there is a port endoscopy, or a tubular retractor can be used along with the endoscopic surgery. So we need to know the various different approaches which can be used in endoscopy. One is the channeled endoscopy surgery, which we use for ETV or even for intraventricular tumor. So in such cases, the instruments are passed through the working channel. Whereas in endoscopic controlled surgery, whether it is, using a port or tubular retractor, in these cases, the instruments are passed by the side of the endoscope. One can say that assisted or endoscopic controlled, but here also no microscope is used. We use a tubular retractor and it is assisted by the endoscope. In channeled endoscopic surgery, you need to have, there is a difficulty in bimanual dissection because the instruments are passed through the working channel. So the angulation and the bimanual dissection is not possible. Whereas if you use port surgery or tubular retractor, there is no difficulty in manipulation of the instruments and bimanual dissection is possible. And therefore, you can have, there is no difficulty in controlling bleeding even if there is a severe bleeding, and the larger and vascular lesion can be operated using this approach, using tubular retractor. And the another advantage of this is that in most cases we use air media, therefore seeing a bleeding vessel becomes very easy. In channel endoscopy also, one can use liquid media or air media. If there's a bleeding which is not controlled, then you can convert this liquid media into the air media to see the bleeding vessels. But by and large, there is a difficulty in controlling the severe bleeding, and it should be done in small and avascular lesions. So indications of channel endoscopy and indication of tubular retractor endoscopic surgery should be known. Regarding the tubular retractor, we know that the force, there is a low retracting pressure when you use tubular retractor, and this is because the distribution pressure is in all directions over the larger area, and therefore there is less chances of producing contusion when you use tubular retractor. We know that there are many tubular retractors available with the advantage and the disadvantage, but most of them are very costly. They are rigid, so therefore liable to cause trauma, need comparatively larger opening, require a holder. There is a time wastage in locking and unlocking, and some of them are having opaque wall, and they are comparatively heavier. The unique feature of our tubular retractor, apart from being very, very, there is almost no cost involved, is that it is very soft, therefore unlikely to cause a trauma. It is a soft silicone tube, and the longitudinal cut which is applied onto this tube allows this tubular retractor to get folded. Therefore, you can put it through a very small opening. So the advantages are that it is inexpensive, it is simple. Regarding the cost, the one tubular retractor costs around 10 Indian rupees only. It is simple, it helps in stopping the bleeding. This is a great advantage. It is effective and safe, requires very small opening. It's soft, therefore there is minimum trauma, lightweighted, can be moved in any direction, no holder is required, and the wall is transparent, therefore you can see around the tumor. Regarding the technique which we use, you can use image guidance, which is important if you have facilities, but if you don't have, then also there is no problem. We have been using CT scan or MRI for localizing of the lesion. Pre-operative, you can have a marker there placed at the center of the lesion, and then you can decide where you want to make a small craniotomy or burr hole, and decide the trajectory accordingly. So even in, but obviously the lesions are larger, therefore we could do in all cases when we did not have the navigation facilities, we were doing the deep-seated tumors and intraventricular lesions regularly using this tubular retractor. After using this with tubular retractor, you can use either endoscope or a microscope or exoscope. The telescope which we use with the tubular retractor is long one. It is 30 centimeter long, 4 mm size endoscope, but you can use the thinner scope also with this. Endoscope holder is also used so that you can use both your hand for bimanual dissection. This is the short video of the colloid cyst which we removed using this tubular retractor. Initially, we were using the channeled endoscopy, but over the time, when we found that complete resection becomes difficult, then we started using this. So you must have seen that we put in the tubular retractor in a closed limb position, and then gradually expand it, and then we put the folded tubular retractor inside this. Sorry. So the nasal speculum, and then we put the tubular retractor, which is folded inside. So you enter the lateral ventricle, take out the nasal speculum, and then put the endoscope by inside this tubular retractor and do bimanual dissection. One can see the colloid cyst at the Foramen of Monroe. Coagulate the choroid plexus, cut it so that you disconnect the cyst from disconnect the plexus from the cyst wall, dissect it, incise the wall of the colloid cyst, decompress it initially, and then try to deliver the cyst in the lateral ventricle, and using two instruments one can dissect the cyst wall from the rest of the choroid plexus, and using the bimanual technique, the adhesions can be cut using scissor. In presence of air media, it is very easy to see. Otherwise, a small little bleeding when you use the air media, everything will become very blurred. So another advantage of air media is that controlling of the bleeding is easy. Now, using a bimanual technique, these adhesions from the cyst wall is removed, and in the end, one can take out the whole cyst wall. We have done more than 30 colloid cysts using this tubular retractor. I think this is another short video of intraventricular tumor, the large tumor in the atrium. This was choroid plexus papilloma. And again, one can see that there is a marker there. and because we did not have the navigation, so using this technique, we can go directly on the area, because this is very important. If you and see, this is the pile stitch which is applied. Another disadvantage of tubular retractor at times, I mean limitation, not the disadvantage, is that if you have a huge ventriculomegaly, if the CSF is drained, then the brain parenchyma falls and the retractor becomes unstable. So to prevent that, we have started using this pile stitch, and we stitch it with the dura, which I mean allows us, which prevents the I mean falling of I mean the brain does not fall away from the dura. So again, the nasal speculum is introduced in a closed limb position, tubular retractor placed, remove the speculum, and then the bimanual technique is used to remove the tumor using even conventional instruments like simple bipolar, or one can use even endoscopic bipolar. But the instrument should be single shaft preferably, and they should be slender so that you can introduce two instruments through this 2 centimeter diameter tubular retractor. Bimanual dissection. And the tumor is removed in piecemeal, and the last piece of tumor being real, and in the end, good hemostasis. Keep a EVD so that you should isolate the ventricle to prevent blood getting inside this, and leave the EVD for some time, for 2-3 days. So we have used this tubular retractor in more than 800 patients of hematomas, intraventricular or basal ganglion or thalamic and deep-seated tumors and intraventricular tumors. Of this, 97 were intraventricular tumors. This technique was found to be safe and effective. There is a low incidence of contusion, but there can be complications like IVH, subdural effusion, or late hydrocephalus. This was pre-op and post-op of subependymoma, and another intraventricular tumor which was operated in one of the workshop, complete excision. But there are limitations of tubular retractors which we use. Migration of tube may occur. So to prevent that, we use 2 sutures at the proximal end and keep it on the drapes. And using these sutures, you can even angulate the tubular retractor if required. There may be brain injury if accidentally the tubular retractor comes out, and when you try to push it inside. So if it comes out, then you introduce again using a nasal speculum. There is a learning curve, obviously, as with all surgeries, difficult to remove the superficial part. If the tumor is lying superficially, obviously there is no need for using a tubular retractor. Difficult to significantly change the direction. Because the brain parenchyma, overlying brain parenchyma prevents that, so you have to have a second trajectory. Retractor can become unstable if there's a large tumor or there is a huge ventriculomegaly. In those cases, use pile sutures and also use sutures so that it does not fall to one side or other side, and use larger size tube when big tumor has been removed. So after initially we use 2 centimeter or 15 centimeter. Later on you can use 2.5 centimeter diameter tube. For detail, you can see our book on neuroendoscopic surgery, where all details are given how to use this and what are the limitations. To conclude, surgery for intraventricular tumor using endoscope and tubular retractor is safe and effective. Large and vascular lesions also can be used when you use tubular retractor. Obviously, using a channel endoscopic surgery, you can use this for smaller lesions, but when there is a large lesion, then you can use tubular retractor and endoscope. Bleeding can be controlled, and bimanual dissection can also is also easy. Obviously, there is some learning curve. Thank you very much. Thank you.
Thank you, Professor Yadav, for this great presentation and the nice technique that you showed to remove the intraventricular tumor. And let us invite our panelists to have few questions quickly or comments. Moody, any comments from your side?
Thank you very much, Gaurav. I think you've answered the question that I had of using a port along with an endoscope. What we've tended to use is not the tube, but essentially a syringe in combination with a Foley's catheter, because that's much more kinder as you introduce it under neuronavigation, and then not have to use the nasal speculum. And then the flange of the, you obviously know what where to cut that syringe. We've used 10 millimeters to start with, but have gone on to the 20 cc syringe, which gives you a good port. And then you've got the flange, which we make openings on and then anchor those to the dura. So we've used the port, but I was just wondering what your thoughts were comparing the two, if you've ever considered using a syringe, which has similar advantages, but may not be as pliable as your tube one, which you can then fold and then retract. But having used a smaller syringe with a Foley's catheter and then introducing it, creating that space, seeing the tumor, taking it off, and then again with a Foley's catheter, introducing the 20 cc syringe to the right depth, has given us an equivalent view. And I wonder whether your thoughts are, if you have ever tried that. Thank you.
I agree with you, but I got this idea of when I was using initially syringe, to be very frank, but then I thought it is little tough, and so why not use some tube? So initially I was using the tube, tubular retractor, soft silicone tube. In fact, my wife saw me struggling putting the tube, so she said, why don't you put in a longitudinal cut on this syringe, a tube, and fold it and put it inside. So I found it useful. I agree, it's excellent. The syringe is also good. Yes.
Sarat.
Thank you, Suresh. Yeah. I think that was an excellent presentation from Professor Yadav. So I have been using syringe for several years, like Professor Qureshi, but I use a 5 cc syringe, and it's cut to almost a very short size. So I would be showing in my presentation. So I use a length which is just required to access the intraventricular tumor using the neuronavigation, and the short length of the syringe allows the surgeon to develop that very nice inverted cone, which is required for minimally invasive surgery. But I think at the bottom line, the the end summary, what we can have is, these are all the techniques which shows that we are moving towards an era whereby we are not satisfied, obviously, because of the obturatives provided by the gap endoscope, because they were never provided for intraventricular tumors. So we are moving into various techniques whereby we do an endoscopic assisted approach using a small craniotomy, and that still becomes a very good advantage to tackle large pathologies.
Thank you, Sarath.
One thing, sir, if you allow me, one more advantage, especially for intraparenchymal tumor of this tubular retractor or any tubular retractor, I think for that matter, is that it stops bleeding. So if you have, during debulking, if you have some bleeding, just gently push it inside and the bleeding stops because of the tamponade effect. So another advantage of this tubular retractor, of all tubular retractor.
Correct. One interesting point that you describe in your presentation is that when you're removing the large tumor or dealing with the large ventricles, there's a lot of CSF or volume removal, and that causes falling off of the brain. And you suggested that pile stitches, but are they enough? How many pile sutures you put? And
three pile stitches, and then you can use tissue glue also along with this. So it works. It works. In larger tumor, we found that there was a falling of this, and your whole tubular retractor becomes, unstable. One is that it doesn't work because the whole parenchyma, thin sheet of parenchyma over the tumor goes along with the tumor. So the surgery becomes difficult.
Absolutely, I agree with you. Yeah. We also have such experience, and we don't know. We tried all those things, but we have still not come to a very definite remedy or treatment for this thing. Sarath, you have any idea?
Well, I can show it in my presentation, but yes, I have found that whenever I use the syringe, the edges of the brain very nicely grasp the syringe. So it's not very easy for the brain to slip around the sides of the syringe. And at the end, once we fill it up, I use glue to close the cortical surfaces. And I think this works. But Professor Yadav's idea of subpile sutures is very good. And if you do it, that's excellent.
Any such experience, Dr. Dev Pujari, Moody? This brain falling.
The only comment I had was to prevent it from becoming unstable, making a small opening in the flange of the syringe and then holding that, and that prevents the movement of that because you've sutured it either to the dura or to the galea, and it doesn't move. That's how I found it, but that would be my comment. Chandra, your thoughts?
I have very kind of flexible approach to this, I should say. I started using the transparent sheath when we used to use Midas Rex drill. All the drill bits come in this transparent sheath. And that was just the ideal kind of thickness and pliability that you could use to make it into a port. And I used that for a few years. Later on, what I have found is that probably it is not necessary. I think once you have got a track made, you usually have it is really necessary, as Sarath was pointing, for endoscope assisted surgery. And if you know that you are going to do endoscope assisted surgery, you can probably use it right from the beginning. But for a purely endoscopic surgery, I think it is not usually required. Yes. If you are going to use only an external suction, which is what most of us do, I think you can probably manage just going along the endoscope sheath.
Excellent. Any other question or comment from anyone?
Can I comment?
Yes, Manas.
Yeah, no, means with the syringe, I find that the edge of the syringe, when you cut to the length of the cortical thickness, is very sharp, and sometimes it's damages the cortex. In that way, Dr. Yadav's technique is a little more softer for the brain than the syringe. How do you manage making it atraumatic, the syringes, the tip of the syringe?
That's where the using the Foley's catheter, when you protrude out just a centimeter away, and once you've dilated the Foley's catheter, it's very soft, and that's what is taking the tube, guiding the tube into place. You're not directly going through the cortex with the blunt, almost sharp edge, because when you cut it, there are little sharpened edges. But if you use it with a Foley's catheter in it and you ballooned it out, you'll find that it's the Foley's catheter that is taking the tissue away, and your syringe is actually following it. Once it's in place, then you deflate the Foley's catheter and you're in where you want to be. So I've not found that traumatizes the brain. It's quite gentle.
Okay. I think we may move on to the next talk now, and this is going to be by Professor Sofyanov. He couldn't be present during this webinar, so he has sent his recorded presentation. So we'll play the recorded presentation and discuss it. I don't know whether they are.
Dinesh?
He's not seen here.
Manas?
Manas, you have the phone number of one of these guys? About technical stuff? Dinesh or
Satish? I'll call.
Anyway,
Okay.
Oh, there it is. There it is. Let us start.
Good day for everybody. Thank you very much for giving me possibility to share our experience in biportal and exoscopic.
Can you increase the volume, please?
Possibility. I am Professor Sofyanov, Albert Sofyanov from Tyumen, from
further increase the volume.
And also Department of Surgery from Sechenov Moscow State Medical University. The endoscopic treatment of the intraventricular tumors. Why it is possible? Because we have
the volume is still very low. Suresh, can it be?
Cavities.
Yeah.
Satish, can you please increase the volume, audio?
Cerebrospinal fluid and
sir, this is a full, and we already shared the sound, sir.
Endoscopic equipment and perspective.
So this is a full, sir.
Give us possibilities, but
one second, if you want, I can please share, sir. One second.
Endoscopy have So I will try to have new ways.
That's better.
To exclude these limitations. So why we find the 3D neuroendoscopy is very useful, and the multi-portal approach is very useful just for improving this current technique. And now we have binocular neuroendoscopy, like a samurai, you see on the slide. For this kind of surgery, we need very good equipment, and this is a view of my operation room for this kind of surgery. This is the equipment and the 3D monitors and the drills and so on. Most important equipment is some endoscope, and we use a lot kind of the endoscopes, like a rigid endoscope you see from Storz, Escola, for example, mainly from the Storz, and flexible endoscope. And also you see the picture. This is not standard endoscope. This is a video scope. We use the chip on the tip of the endoscope, and the quality of the picture is excellent now, and like a Regis endoscope, so give more new possibilities for this kind of surgery. And also we use same Regis endoscope also. You see the very thin, near the 1 millimeter endoscope. Also, we have a lot of instruments what we need because now we improve our technique for the bimanual technique. So we need some instruments like a forceps, scissors, and so we have this instrument now. And also we use a new tool now for this kind of surgery. Not only endoscope. Now we use exoscope. You see. The step of the operation, you see the exoscope. By exoscope, we see the endoscope, because during the endoscopic surgery, most dangerous area is not only anterior to the tip. The most dangerous area is around the endoscope. So this blind area possible to control by the exoscope. So the safety and possibilities of this kind of surgery improved. For multi-portal approach, I introduce new classification of approach. The approach depends from the localization of the approach. It depends like a monoportal, it's only one port, for example, or multi-portal. Multi-portal we divide by the biventricle or monoventricle approach. Another options is the type of port. So it's possible to use pure endoscopic port, the sheet of endoscope, for example, from GAP, from LOTA, from mini LOTA, and so on, PIROA, for example, and so on. Another new possibilities is assisted port. Just for only this assisted port, it's possible to use only for endoscope or only for exoscope, for example, like you see. And for this kind of port, we standardly use tubular retractor. Also main advantage of this port is the transparent of the wall of these tubular retractors. Improve our possibility in this kind of surgery. Another also option is the function of the port. The port possible use only for visualization, for example, standardly we use, or only for another port, for example, with only for work. But in some cases, in some difficult cases, it's possible changed by the place, for example, or other combination. So main important is the port combinations system, and all options possible combinate. All portions possible to combine. So it's open very wide possibilities for the safety and the totally removal of tumor by endoscopic approach. This is an example of the operation field. For example, with the monoportal approach, no big craniotomy, just only one bar 4, for example, like this. And this is a pure endoscopic options, for example, for removal tumor. This is a multi-portal, by the example by biportal approach. You see the one is the port, a pure endoscopic port for endoscope, for visualization. Another is port for the instruments only. So with the biportal approach, this is not combined. This is a standard technique for biportal. One port for the visualization by endoscope. Another port is for the working port for the instrument. But again, a lot of combination is possible, as I showed before in classification. Also very important in endoscopy now is neuronavigation system. So again, we use also neuronavigation system and possible to navigate operation seat of endoscope, and it's very important, especially in difficult case. New possibilities, what we have also open new horizons for this kind of surgery. For example, we have a hybrid ICT operation room during operation with navigation system, especially in difficult case, where in cases we have great possibilities, for example, for orientation. Another great options now is laser. We use thulium laser. This is a laser with the improved characteristic for the hemostats, coagulation, and so on. Another classification is for neuroendoscopic surgery of ventricular tumors is the option. What options is possible in this kind of surgery? First and main options for really minimally invasive neurosurgery is total pure endoscopic removal. It's possible. Another option is the partial pure endoscopic removal. Biopsy, endoscopic assisted removal, and the management of the secondary hydrocephalus. These are the main options in this kind of surgery. But this kind of surgery depends from the anatomy of the anatomical feature of the ventricles, localization, lesions, size of ventricles and lesions, vascular subprime, and one of the main important is the learning curve or experience of surgical scenes. Approach, I classified approach by the also entry point, because entry point to Monroe is very important because we have rigid bone structure. So why the entry point is very important, just to access without any damage of the brain tissue. So why main important is the anterior transventricular approach. For which tumor? The tumor of the localized near the foramen Monroe, near the inside of the frontal horn, body, third ventricle, especially posterior part of the third ventricle, interthalamic hemisphere, and also for the tumor localized in aqueduct, like you see in this picture. Again, middle transventricular approach. Also, you see how I do it. It's for tumor, mainly tumor near the Monroe again, tumor in the body of the lateral ventricle, and tumor of the third ventricle, mainly on the floor and middle part, and also chiasm. This is the main indication for this kind of approach. Another is the posterior transventricular approach. You see, for the tumor, main localization of the tumor is the atrium. You see like this. Also posterior bone is possible. Body of the lateral ventricle, glomus, and the inferior horn also is possible. So this is main approaches, main three approaches for practically all part of the ventricular system of the brain. Also, entry point. Again, entry point is very important because the first entry point is very rigid because it is the bone of the skull. So precise localization is very important for this kind of safe minimally invasive surgery. So with the scheme about this approach, for example, for anterior approach, you see the entry point, and it's possible localization for the instrumental ports. For example, this one. Standardly we use this one and this one, but if necessary, difficult case, lot of vascular vessels, vascularization, and so on. Others difficult. For example, it's possible create more. For example, 3 port, 1 endoscope and 2 port for instrument, for example. And it's possible to change, for example, by the circle visualization endoscope. It's possible to use here, possible to introduce here, for example. If not enough visualization, possible change here. Also, same for the instrument. Also, possible to change by this circle, for example. If not necessary, possible to create more and more, because main criteria for this kind of surgery is the safety for the patients. Not only limitation. You have any limitation. If you need more, you create more. Main is patients' life and quality of life. And another is, for example, posterior approach. You see, same. And now I want to show some cases about possibilities of this kind of surgery. For example, this is a very small baby, 6 months old, and they have big tumor, fills the third ventricle and go out from the third ventricle inside of the lateral ventricle through the Foramen of Monroe. And this case is big challenge for the any surgeons, because a small baby, and a lot of vascularization. Even for open surgery is difficult case. But for when I decide about operation in this case, if I create big craniotomy, even big craniotomy in this small baby, is big problem. So I decide to operate these patients by minimally invasive surgery, by biventricle biportal approach, pure endoscopic. You see, I introduce endoscope by one port and review the system, possibility of surgery. You see the tumor inside, and I try to dissect and remove piece by piece. So from second port, I introduce instrument like a ligature. You see this. You see the ligature forceps. What I introduce through the second port. You see ligature, and by ligature, it's very safely and very quickly. You see the coagulate and cut, and piece by piece, I remove this tumor. This is biportal work. You see bimanual, biportal work. Ligature, forceps, bimanual work. And piece by piece, very safely, very fastly, and totally removed. I totally removed tumor by this technique. You see bimanual work. Very, very, very important. And you see this last piece, we remove, and this is operation. You see the completely total pure endoscopic biportal removing of the tumor. Another case, also big vascular case inside of the lateral ventricle, and we have big. This is the second port. I introduced instrument through the second port. You see the picture, view of the operation. Second port, you see, this is from first port. I see how to introduce second port. Very safely, main important. And then after, I start to divide the vascular peduncle, because very big vessel, you see how it's big artery. So I don't use coagulation. I use clip. Smoke guarantee. You see, clip. Instrument I introduced from the second port. Clip. And then cut by scissors, and then remove. This is one of the first cases. So a lot of clips I put inside because I'm a little bit afraid. No experience before. And you see after operation only 2 ports, no craniotomy. This is only two small incision. And even in this difficult case, in challenge case, just only 5 days and a patient go out to home. Even so small baby. It's really minimally invasive surgery. Another case, no limit. Now no limit. You see the lot of tumors inside of both hemisphere, inside the both ventricle. Very giant, very big, lot of supply of the vessels. Very risky. But also I decide to operate endoscopically. First one from the left lateral ventricle. First I check the possibility, possible, not possible, possibility of dissection, and I reveal the good supply, vascular supply, and start to dissect and coagulate the vessels. You see, not necessarily fast operate. It's most important is precise cut the vessels. If you precisely cut the vessels, no bloody, no problem. Step by step, coagulate, cut, coagulate, cut, coagulate, cut. But you must cut only coagulation part. If you walk like this, no problem. If you walk, cut not coagulation vessels, it will be problem. And this is how we remove big tumor from very small, like a fishman. You see on the ice. Check, no tumors, totally removed. So I moved to another hemisphere, another ventricle. Also, same procedure, one port. Also, dissect the peduncle, vascular peduncle. Also, dissect, and also very precise work, coagulation, cutting, coagulation, cutting. And then removed from another ventricle. Also, you see, very small port, but it's possible to remove big tumor. Check the system, ventricular system, no tumor inside, so totally removed, completely totally removed. Just 30 minutes one side, 30 minutes next side. You see, and totally removed. It's really minimal invasive surgery. Again, no craniotomy, big craniotomy, just only like a bar hole. After operation. And also another case, big colloid cyst, very adherent to the foramen of Monroe and critical slug around the foramen of Monroe. So I decide to operate also by multi-port approach, biventricular approach. You see the anatomy, Monroe, and you see inside of the short ventricle, very big, very dangerous adherence. Why I decided to cut the septum periods and above, and use also biventricular approach. You see the instrument from another port, coagulate, just under visualization. Again, I introduce another instrument from another port. And the good visualization is a big advantage of this kind of biportal approach. And total removal of the colloid cyst. Also, combination. Now we start to use combined approach, like we use tubular retractor, like this big one, and through this retractor, it's possible to use exoscope, endoscope, and instrument, and remove tumor from inside. You see example of using the 3D endoscope, for example, just for this kind of surgery, through this tubular retractor system. Thank you very much. And again, we are from Tyumen, the Federal Center of Neurosurgery, and again, main principle is a strong clinical base, a strong neurosurgery. So we have a good system for the training young residents step by step. You see the simulation lab, cadaver lab, full body cadaver, wet lab, and so on. And thank you for attention. And we are open for young neurosurgeons. If you have some information about residency program or the fellowship, you possible to use the links about this. We are open, welcome. Thank you very much. Sure.
So that was an excellent presentation of this special technique by portals. Do we have any comment from anybody? Sarath, what do you think?
I think this is all a part of the continuum where we are progressing ahead. So biportal obviously is a natural mechanism which we have to evolve. And I have been saying it for several years. Biportal is a very accepted technique for lab colleagues, and they've been doing it for several years. And we have to also slowly adapt to it. Because unless we do, we will not be able to tackle the larger pathologies. The small pathologies are fine. ETV is fine. But unless we evolve into biportal techniques, we will not be able to tackle the larger and the more challenging pathologies.
Absolutely right.
Yes, I think Albert's presentation obviously reflects the kind of advances you can make if you have a good support from a very powerful backer. And I think they really have invested a lot in his center, and it shows in his presentations. If we are going to do it in our settings, I think it is possible, but I think the two key elements are neuronavigation. And if we have neuronavigation, we need to have fiber tracking. And if we can look at those tracks and safely decide which is the best path to take, and then use biportal or even various portals, I think it becomes safer. But without neuronavigation, without tractography and an understanding and a good discussion with your neuroradiologist of which tracks to take, and obviously one can do that yourself, but having that team is going to make things safer. And as Sarath says, I think what this conference is highlighting is really the progress that can be made with forward thinking, opening up paradigms. And it's not just about the equipment, as we've seen from others' presentation. It really is not investing in major equipment, but yes, Albert's is unique. He's got a lot of backing, and congratulations to him. I know he's not he's not online, but really the support he gets from his state is excellent. But even without that, I think if we can learn to use our tools, even if they are not as expansive, if we can use them with neuronavigation and fiber tracking, I think we should be able to achieve a fair amount of that. But excellent discussion, excellent talk, excellent lecture.
Excellent. I agree with you, Modi. What is more important is that, yes, whatever the cases he had shown, the larger tumor and all these things are obvious indications. But what really is interesting is to see him doing choroid plexus. Some of the choroid plexus do require the vision from the other side. And that is where probably the double port technique will really help. And same is with the choroid plexus papilloma, where you have to look for the pedicle, and sometimes with one port, it is very, very difficult to visualize it and control it at the same time. So these two indications are definitely are there, and this technique has a role in many surgical techniques and surgical procedures. But at the moment, I think the larger tumors, the choroid plexus, papillomas, as well as some of these colloid cysts do require this kind of rentgen. It's very helpful. Dr. Bhartia has something to say.
Hemant.
Unmute yourself, please.
Yeah. Can you hear me?
Yeah.
Yes.
Okay. Because he is not here, I think I can direct that when you are using biportal technique in such cases, what is the location of the burr hole of one port and the other port in relation to the tumor? So it is fixed or it is to be defined differently depending on the extension of the tumor in whatever direction it is. And second question is about the epilepsy difference between the using one portal and biportal. Is there any incidence difference in epilepsy?
Yes. So your question is to whom? Maybe Moody would be able to answer this properly.
Well, I'm not sure that I'll be able to answer that properly, but having said that, I think the previous remark that I made, I think the approach, you can't have a fixed approach to those portals. And that's why I think Vikram's lecture on neuroanatomy was most apt, because it tells us what are the structures that we really need to avoid. And as I mentioned, the tracks, and the tracks really come from our tractography, because those are going to be displaced, and where the some of those tracks are, and what is the safest and the most direct approach to that other side using your other portal, and which are the tract-free areas or safe zones. I think you can't have a fixed idea that the ports must go in from this particular site, as one does with an ETV. You know that you're going to go 12 centimeters or 13 centimeters, you're going to go in the precoronal area, and bang, you're going to go through the foramen. You can't do that with tumors. You'd have to be guided by your fiber tracking and your neuronavigation. I would think that would be my comment.
Absolutely right.
Actually, Albert tried to show some kind of algorithm for where to make burr hole for bioportal approaches for depending on the location of the lesion. But unfortunately, he is not here to answer the question.
May I make a comment?
Yeah.
Yeah, sure, Vikram.
So further to Dr. Qureshi's comments, it's quite apt. And I think we are already probably doing a two biportal approach when we do two burr holes for a posterior third ventricular biopsy along with an ETV. So that's something that is already a well-established sort of procedure. Now, there is some literature which says that with two burr holes, the potential for damage to the fibers is little higher, but that is offset by the safety profile of not damaging the fornix and intraventricular structures. So, I mean, that is something that came up during my reading for this talk as well. So maybe there is some added damage to the tracts, but if you outweigh that, the advantages that you have, probably biportal for complex tumors may have a role.
Is that when appropriate fiber tracking has been utilized? Because if you don't use the appropriate fiber tracking and you don't know where those tracts have been displaced, then I agree, I think you're going to damage them. But if you've got your tracks very well defined, and then you approach your trajectory, I suspect that might not hold so true, but I haven't seen the paper that you've described. You're muted.
It's within the last 6 years or so. So, but I'm not sure if they've used actual fiber tracking data for this paper, but I will get back to you on this. Let me just.
No, but it's very helpful to know that, because one goes away with the impression that if you've got your tracking right and you've got your trajectory correct, you're not going to avoid damage, but at least your damage will be minimized. And I think and everything we do in our field and many surgical fields is a balance of which is the safer approach. And I think, like you say, not using the biportal and then being concerned about the damage you might do to the fornix, although we've heard from our colleague that is not one of his major concerns, but it's always been ingrained in us that really avoid the fornix at all cost. So on balance, I suspect one would have to look at meta-analysis of this at some point in the future. But I get the sense that one is going to be more inclined, as was mentioned by Sarath, that people are using the gastroenterology surgeons have shown us that you can get into various tumors and remove kidneys and remove all do major liver surgery through multiple ports. And I think of course the brain is a different animal in the sense that it's got all these tracts that we need to avoid, but I would imagine that we will find the safe tracks with the appropriate trajectories that will cause least harm. And on balance, I see this pendulum swinging towards a multiportal surgery once we get our knowledge base right. That's my take from what I've been hearing. Thank you very much for a really illuminating session.
Absolutely.
Suresh, Pathak wanted to comment something.
Is he around?
Yeah.
Ashish? Yeah, go ahead, please, quick.
No, my question to the learned audience is that I have done about 136 now transcortical procedures of various kinds using endoscope, not using endoscope. And this myth of having Caesars going transcortical, even in the days when we didn't have any tractography, I am fortunate, or I don't know whether it is true, I have not yet encountered a case where I had seizures because of going transcortical. So is it really that strong a belief, or is it a fact of that kind that any transcortical aggression or transgression will definitely have seizures? What's the exact incidence? I'm not really very sure. Now we have got tractography, that's fine. We try to avoid it, but how much really does it happen? I mean, I have fortunately not faced one. So I'm asking to all my learned friends. Have you ever have you had seizures because of transgressing the cortex for going to the ventricle through a small port or small hole or a small retraction or small opening, or the endoscope we are regularly using? How many cases are there?
Yeah, microscopic means they have compared transcallosal and transcortical excision of colloid cyst.
In the literature, but I have not seen one. Have you seen one happening in your
personal experience, you mean?
Yes. Literature says yes, go transcallosal because you want to avoid seizures. And
yeah, but literature says both have equal incidence. Though we believe that transcortical has a higher incidence, but literature says whether you do transcortical or through the corpus transcallosal, the incidence is similar. The only difference is the early seizures are similar. Only the late seizures after 1 year it persists in transcortical, not in transcallosal.
Seen happening in your own personal experience. I mean,
transcortical, yes. I have seen in both transcallosal and transcortical.
Seizures. Okay.
Yes.
I've been lucky that way, and that's the only thing.
No, I'm lucky that way. You are lucky. You didn't have.
Okay, I think we are running short of time, and
in terms of time,
so
we have also seen. We have also seen seizures.
Sarath and Manas still have their talks too.
So I think let us move on to the next talk, and that will be by Professor Sarath Chandra. Professor Sarath Chandra is a professor of neurosurgery at AIIMS, and he has a tremendous work in the neuroendoscopy and contributions to the Neuroendoscopy Society of India. He's going to talk about the endoscopic and endoscopic assisted excision of large intraventricular tumors. Sarath?
Yeah, am I audible?
Absolutely, yes. Please go ahead.
Thank you very much, Suresh. At the outset, I would like to thank you, Professor Dev Pujari and Professor Moody, for giving me this opportunity to present here on this very nice platform. So I would be speaking on my own experience of using endoscopy for large intraventricular tumors, especially the use of robotic guidance and also creating a custom retractor with a syringe, like Professor Qureshi was mentioning. So obviously, when we speak about access to intraventricular tumors, we either speak of pure endoscopic, which is done through a burrow, which is underwater. And this is quite okay for small pathologies like colloid cysts or septal gliomas or even biopsies. But however, for large tumors, obviously, this is not what cannot be done. No, we have to go through a different path. We have to think of something like an endoscopic assisted through a small cortical flap. And this is a limitation of technology. So another adjunct which could be added is a robotic arm, and we have acquired this ROSA system, which we use it very actively for putting the stereoencephalography for epilepsies. But in addition, we've also been using it in conjunction with an endoscope, and that allowed me to develop the technique of endoscopic hemispherotomy as well as endoscopic corpus callosotomy with commissurotomy for the first time in the literature. And we published several papers on this. And now this is a standard procedure in our own institute where we do a complete hemispheric disconnection through a small craniotomy of just 3 to 4 centimeters. And the same technique has also now been taken up in several institutes across the world, wherever they practice large volume epilepsy surgeries. So this is how I use the endoscope along with the robotic arm, which is the ROSA. And it's very important for the surgeons to maintain the proper ergonomics in terms of visual access, in terms of using a long scope, having a proper elbow support, and having an optimum back support. And the advantage of using a robotic system is that it provides a very good haptic feedback. So you can change even minute amount of axis changes to either side. And that is very important when you're dealing with large pathologies. For small pathologies, it's fine. But once you deal with large intraventricular tumors, it could take a couple of hours or several hours, and one needs to have a proper holding system. Now, the limitations of pure channel endoscopy, as already mentioned by Professor Yadav, is in the technology itself. The obturators which are been developed have not been developed to handle large pathologies. They were never designed for tumor surgery. They were designed fundamentally for endoscopic third ventriculostomies. So this is how we do. We either do a transcortical approach, which we use a 3 centimeter circular flap using a drill. We don't use the burrholes because burrhole leaves again can leave a large dimple. And similarly, we use an interhemispheric corridor for midline tumors. And again, this has been adapted for endoscopic hemispherotomies, where we had the experience of doing an entire hemispheric disconnection through this opening. So we have used robotic system for more than 100 cases. So obviously, it's a very stable holder. There is an excellent haptic feedback. So there's no exhaustion to the surgeon. The issues with the traditional holder is that moment you let go of the holder, the entire weight of the endoscope falls on the hands of the surgeon. And that could become tiring over a period of time. But when you're using a robotic system, there's a very nice haptic feedback. So you could release it several hundred times, but still you could not feel any exhaustion. It also doubles as a neuronavigation. But there are disadvantages, obviously, that it's very expensive. So unless you are using it for all the other indications, nobody would like to invest in it. And sometimes the arms can freeze and there is no fast movement. So this could be an issue sometimes. Now, I started using a syringe like Professor Qureshi was mentioning almost 15 years ago. And I prefer to use a 5cc syringe, and this could be cut up to a very short length. The idea is to just reach up to the surface of the endoscope. And I used it for several hundred cases for intraventricular hematoma, intracerebral hematomas. So obviously, when a syringe is cut up to the level of the tumor, it can be easily moved both outwards and inwards. The outer flanges prevent the syringe from going inside, like Professor Qureshi was mentioning. The short length, I find, allows the surgeon to develop this tunnel, which is very much required for minimally invasive approaches in a very nice and a comfortable manner. Now, I did try to use this commercially available. I think I missed a slide. Give me a minute. Oh, yeah, I'm okay. Sorry about that. So I did try to use this commercially available obturators, but believe me, I found them absolutely, I would say, useless, because they occupy a lot of space. And in addition, one cannot customize the size. So one finds that the size is too large in most of the time, and this prevents creating a funnel-like approach, which is so much required for minimally invasive approaches. So this is just to show a video where I was using the syringe in several hundred cases. In fact, all the cases which I contributed to STITCH trial, which was around 60 from our center more than 15 years ago, was all done by using this technique. And you can see that by using this technique, one can evacuate the hematoma in just a few minutes. So if you use a proper trajectory along with navigation, you end up evacuating the hematoma completely. And this happens
your video is not showing.
Few minutes.
Your video is not showing.
Or the video is not showing?
Yeah.
Is it showing now?
No, sir, only audio is coming. No video.
You are stuck on slide number 15, but there is no video running.
Let me unshare and then let me share again.
Yeah.
So were you able to see the slide earlier? Are you able to see the slides, Suresh?
No, sir.
No.
Oh.
Right now there is no slide.
Oh, what is that?
I think reshare the screen.
Can you see the slides now?
Not yet.
Why?
I think the internet connection all through is not very good everywhere.
Can you see the screen now?
No, Sharath, not yet. I think you just come out and register again or something. We can see you, but your screen is not visible.
Can I log out and register again if you don't mind?
Yeah, please do that quickly.
Am I audible, Suresh?
Yes, you are.
You are audible.
You're audible. Yeah.
Okay, now can you see my screen?
Yes.
Yes. Now the screen has come.
So where did we stop last time?
Slide 15. Slide 15.
1-5.
Okay. Here?
Yeah.
Yes.
So is it seen well now?
You can see the slide, but there is no video here.
Yeah, there's no video here. I'll come to the video in the next slide.
Okay. All right. Fine.
So summarizing, I tried using this commercially available translucent retractors, but they were of no use, fundamentally because they were quite thick, and one could not customize the length of the retractors. So is the video running now?
Yes.
So I have been using this technique for almost 15 years, and I contributed all the cases to the STITCH trial more than 15 years ago. And one can see that by using this technique for intracerebral hematoma, you could evacuate the hematoma clot within a matter of few minutes. So was the video seen now, Suresh? Hello?
Yes, video is well seen, Suraj.
Thank you. Thank you. So we also published our experience of using a biportal technique, but in the biportal in the sense that it was only through the same opening using a syringe for colloid cysts. And I'll show you a series of videos, not only for colloid cyst, but also for the other tumors which we have operated. So is the video, I'll just run the video. So is the video running, Suresh?
Yes, yes, it is running.
Okay, thank you. So let me know if it stops sometime. So that's a colloid cyst. It's a biggish colloid cyst. Now, as you can see, it was covered completely by the choroid plexus. So we are, as a first step, now this is a pure endoscopy, which I used using a 2 cc syringe, but it's completely underwater. So puncturing the cyst. Now, when the viscous material comes out, we introduce a catheter inside the cyst, and we use a 3-way. One of the arms of 3-way, as you can see here, is connected to the assistant who aspirates it through the 50 cc syringe. Now, 50 cc syringe may sound to be very, very strong, but it's only when the catheter is inserted inside the cyst that we use a 50 cc syringe, and this provides a very powerful suction tool so as to suck away all the viscous material, which is very important, because if this viscous material goes into rest of the ventricle, it can predispose to formation of hydrocephalus at a later stage. So once the entire viscous material is removed, so that is a time when we introduce a second instrument, which is a scissors, and cut off the cyst wall at the level of the pedicle. Now, even though this is a biportal technique, it is through the same port. So I wouldn't call it a biportal, it's a bi-instrument technique where we are using 2 instruments through the same port. Because I did try a biportal technique for colloid cyst, but it becomes very disorienting if you make a second burr. And again, I was concerned about the incidence of seizures or causing more of damage to the brain matter. So once the cyst wall is removed, the residual cyst wall can be cauterized. And I have never seen a recurrence happening with this technique. And we have follow-up right now up to 15 years. And then we do a septostomy in order to communicate both the ventricles. Suresh, is the video running?
Yes, very well.
Thank you. So that is a post-operative CT scan. Now, using endoscopic assistance, that is opening again. Now, this is an interhemispheric approach. So obviously, I don't use a syringe here, but I use the same kind of a technique which we have developed for endoscopic hemispherotomy. That is a endoscope tagged to a robotic system. And it is through a small craniotomy. And you can see this provides a very nice axis of visualization. Now, this size of the craniotomy is about 3 into 3 centimeters only, and it is magnified because we are using the thick endoscope. So it becomes more like an exoscopic surgery. But the advantage is because we are using the endoscope is able to pass into the cavity. So it's part endoscopy and part exoscopy. And that's the corpus callosum coming into view. This was for a large cavernoma just underneath the corpus callosum. And for those of you who can see my videos on endoscopic hemispherotomy, this is exactly the same type of approach we do when we first perform the corpus callosotomy. So opening the corpus callosum, then freeing the cavernoma from all the sides. And it's very important to try to take it out in toto, because cavernomas are known notoriously for having some residue left behind. And that's the end of the surgery, very clean surgery, and showing a complete excision. Now, this is a large recurrent neurocytoma operated elsewhere. And again, we did an interhemispheric endoscopic approach through a small opening. The earlier approach was through a lateral approach. So that's a corpus. Now we put gel foam which are wet on either side, so that these gel foams, when they expand, they increase the space of access to to the tumor, and that's the tumor which is now getting exposed. So I'm running it on 2x speed in order to hurry up the video. So that's again the post-op. Now this is a large optochiasmatic glioma in a 4-year-old boy. So you can see it going right up to the base, and we again approached it from an interhemispheric approach. Now, normally we should not approach these tumors from a superior axis because there is a thin floor of diencephalon over the tumors. But in this case, of course, the tumor was going through that. So there was only a very, very thin cover, and we could immediately come onto the tumor. Now, one of the small tips is instead of using cotton, I often prefer to use small wet gauzes because I find them really hemostatic, especially for large intraventricular tumors. Because the cotton it gets soaked with blood and loses its power to absorb or keep the hemostasis on, whereas gauze has larger spaces, so it allows us to achieve good hemostasis. Now these are a few examples of transcortical approaches. It's a 24-year-old male presenting with headache and vomiting. And this is a highly vascular tumor, which is a meningioma. Now, in this case, I did try using the transparent retractor, and I really hated this. So you can see the limitation. So the whole transparent retractor tapers down to a very small opening, and it doesn't allow you to have any amount of flexibility. And this was a very highly vascular tumor. So I did manage to take it out, but then definitely I decided that this was not the way to operate. And you can see the visualization is not good at all in this case. Now, idea of the operating these tumors is just stick to the center. So as you keep on removing the tumor from the center, the tumor from the periphery again moves to the center. So it's not necessary for anybody to make large openings. If you stick to the center of the tumor, in large tumors, they fall to the center moment you decompress the central areas. And at one point of time, you will end up seeing the parenchyma, and the bleeding also reduces. So that's the end of surgery, achieving hemostasis. This was a parenchymal tumor. I'm sorry, it was not a meningioma. That's a post-operative CT scan showing the small access to the tumor. Now, this is an example of a meningioma, large intraventricular meningioma, which we again operated using a syringe, 5cc syringe. No, I'm sorry, this is not 5cc syringe. We used a large endoscope using a free hand dissection. So rather than using retractor, it was just using dynamic retraction using suction as well as a bipolar. So we did not apply any kind of retractors. The entire retraction was only by suction and bipolar. And we went through very small corticectomy using an endoscope which was tagged to the robotic system, attached to a robotic system. And that's a tumor which has come into view. We can see it's very hard tumor. And using the CUSA. Now using the free hand dynamic retraction using both suction and the bipolar through a very small corticectomy using endoscopic assistance is a very powerful tool. And it's surprising how one can actually access to large tumors using this technique. So that's the attachment of the meningioma, which has been taken away. So again, showing the size of the opening. That's an MRI showing some amount of residual blood. We did it in 3 days, 3 days later, just to ensure that there was no edema. So you can see it's very minimally invasive, no surrounding edema, no damage to any surrounding areas. And these are a few examples of colloid cyst. That's a post-op. It's a pre-op and a post-op. It's a large tumor ependymoma. That's a post-op CT scan in the center. And again, a choroid plexus papilloma. That's a post-op developed cyst. We had to do a shunt there. That's again a large choroid plexus carcinoma. It's a post-op. It's a central neurocytoma, again operated interhemispheric. That's a post-op scan. So the advantage of this technique, obviously what I said is interhemispheric, use a mini craniotomy, use dynamic retraction with a suction and the bipolar. Now, whereas through cortical, you could go using a syringe. And the advantage is you could use the endoscope as a flashlight. It provides light within the cavity. That visualization is excellent. The ability to look around the corners. You could move the scope closer and further away from the operative field and provides the same perspective of magnification. And these have been my experience, about 86 cases. And so concluding, since my time is over, minimally access surgery is an advantage for intraventricular tumors, paradoxically, because when we deal with large tumors through small openings, we have to stick only to the center of the tumor. And as we keep on decompressing, initially it could be overwhelming because of large amount of bleeding. But as the tumor gets decompressed, the bleeding reduces and the surrounding brain pushes the tumor to the center. I found using the syringe for transcortical approach to be excellent and dynamic retraction with suction and bipolar to be very good for interhemispheric approach. And the same thing I've been using for pituitary also. So I think that the use of endoscope for more than endoscopic third ventricular ostomy is a powerful idea. And it seems to what extent that the surgeon can use it to his or her advantage. So Professor Yadav has used it very nicely with a very highly affordable expandable retractor, and other people have used the syringe, the technique of using the syringe to use it, especially to cut it up to the length of the tumor. But the whole idea is that we are in the process of developing various technologies by which we will be able to reduce the size of the craniotomy, make it more minimally invasive, and eventually quite safe and effective to operate such large pathologies. So I invite all of you in 2022, hopefully when the pandemic is down, for this International Society of Minimally Invasive Neurosurgery, which is to be held in Udaipur. So thank you very much again for giving me this opportunity.
Thanks, Sarath, for this beautiful presentation. Unfortunately, there is little time left for discussion, but we can have one quick question or comment from anybody before we move on to the last speaker of this webinar. Any comment from anybody?
So basically, I would like to make only one comment. What Sharath showed in the last few cases, and this is what I was trying to talk about. This is something what we used to dilate the tract before we put the retractors when we used to use them earlier, or even if we don't put a retractor. But what I would like to say is that the dynamic retraction works quite well. So if you are not using too many instruments, I think your suction works as a beautiful retractor during your surgery, and therefore in every case, it is certainly for a short procedures, it is probably not required to put a retractor.
I completely agree with Professor Deopujari. For the interhemispheric approaches, we have been doing hemispherotomies through such small openings. So it's amazing to what extent you could have the plasticity of the brain. So once you let out the CSF, once you're very carefully retracting it, you'll be amazed to see what amount of space you could actually create within that area.
Very nice presentation. I think most of the situations yours is more of an exoscope, isn't it?
Yeah.
The long endoscope which I use now, this we published in the Journal of Neurosurgery. So I called it as a hybrid technique. The reason I called it as a hybrid technique is that unlike exoscope, it's not outside. Now, unlike endoscope, it's not very close to the target. So it is slightly away from the target, somewhere midway. And by that, you are able to have a grasp of the entire target. So when we are operating pituitaries, the size of the target is only 4 millimeters. So a 4 millimeter scope is okay to cover your entire target. But when you are operating larger pathologies, which could be hemispherotomies or large tumors, then if you're so close to the target, you may miss the forest there, you may miss the holistic view. So it's somewhere in midway. And that's precisely what we called in our paper, which we published in JNS. We called it as an hybrid. So it's midway between the exoscope and an endoscopic assistance. So somewhere it's midway.
Expanding the width of the field.
Absolutely, sir. So that expands the width of the field and gives you a very good perspective of the entire footplate of the target that you need to access.
Thank you.
Okay. Thanks a lot, Sarath, for this beautiful presentation. And now we come to the last talk of this day, for which I would like to invite Professor Panigri, Manas Panigri. He is from KIMS, Hyderabad, and he is presently the president of Endoscopic Society of India. Dr. Manas, please.
Thank you, Dr. Suresh, and I'd like to thank Professor Deva Pujari and Professor Qureshi for doing the collaborative workshop of WFNS Endoscopic Committee with the Endoscopic Society of India. The webinar has been accepted very well with a lot of viewers. I was just going through the number of viewers here, and the content has been quite exciting. And at the end, my talk is like a summary of what has been done. With all the experts talking on everything which can be done with endoscopy, and all the residents who listen to it, this may jump to endoscope for every case, every intraventricular tumor they see. So I will optimize when to do an endoscopy and when to do microscopy, and what are the advantages and disadvantages taking cases from our experience. I'll be concentrating only on the lateral ventricular tumors, not on third ventricular tumor or posterior third, to make it simple. When we were residents, when we had a tumor in the lateral ventricle, we were taught either do a transcortical or interhemispheric. And as Professor Ashish Pathak and Professor Hemant Bharati also was pointing, that the incidence of seizures was higher in transcortical. That is what we were taught, and that is what was in the literature at that time. And people preferred interhemispheric or transcallosal approach. But then now people prefer endoscopy, which is again a transcortical. So are we in a retrogressive way or a progressive way? So at the means we have reduced the size, but then I don't think we have reduced the damage to the cortex. So we have gone from transcortical to a smaller transcortical, and the incidence of seizures with endoscopy has not been reported. So we have three approaches where the cortex is breached, both in transcortical and endoscopy, and in interhemispheric, there is no cortical breach. Now, which is a better approach when we get a patient in the OPD for a particular tumor, whether it's a transcortical either with microscope or endoscope or interhemispheric. So for a better approach for a particular tumor is either or decide a transcortical or transcallosal, or we decide how to do it, either transcortical, and what equipment to use, whether a microscope is a better equipment or an endoscope, whether you use an exoscope or an endoscope, which is a better equipment. And all patients do not fit into endoscope. There are many cases which all of us agree that half of them where we need to use microscope. Now this paper came long ago, where they reported, this was in 2006, where they reported the criteria for selection of a tumor biopsy or resection. Though many people tell that 2 centimeter, they have gone till 3 centimeter size where one can do an endoscopic resection. But to do a biopsy, there is no size limit. But for a resection, 2 to 3 centimeter. But more than 3 centimeter, probably microscope is better or an exoscope. An exoscope is just an extension of microscope. So we have to be very clear that transportal endoscopy and microscopy are similar. except for the visualization. Now, this is a review article in 2017 where they reviewed all the transcortical endoscopic approaches for intraventricular lesion, and what they concluded was that smaller tumors and cystic tumors are good for transcortical endoscopy in the hands of all neurosurgeons, not in the hands of experts. Can somebody mute this thing? There are a lot of somebody is driving and his phone is on it. Now, this paper came in again 2013, where they analyzed this systematic outcome analysis of the complications of neuroendoscopic resection of intraventricular tumor. And the reported complication is 20% or 20.8%. And the extent of resection was good, like 95% if it's less than 2 centimeter. But when it's more than 2 to 3, the extent of resection reduced to 75%. So it's effective in less than 2 centimeter tumors and cystic tumors. And complications rate were also higher in solid tumors. And 20% complication rate is something which you have to think of. Now, whether the 20% complication rate is higher than the microscopic group. Now, there are few papers on the complication rates of microscopic transcortical approach to intraventricular. The complication rates are almost similar, but then the motor deficit were a little higher and language impairment also was higher. But then in the endoscopy, this was not addressed to. 19% had post-op seizures immediate, but persistent post-op seizure was only 6.8%. And unlike the transcallosal has less. Hello, can you hear me?
Yes, Manas, we can hear you, but I think please all others go mute, please, during the talk.
Please mute. Dinesh or Satish, can you please mute everybody?
I think Hemant, your mic is picking up a lot of signals. Yeah, go ahead.
Yeah. But in transcallosal, unlike what we believe, the incidence of seizure is similar to transcortical, like 18%. The only difference is there is no long-term seizure, like 6% in a transcortical. So I didn't find a comparison of the complication rate in endoscopic versus microscopic assisted intraventricular tumor, but this was a comparison of endoscopic and microscopic resection of deep-seated intracranial lesion using a portal retractor. And what they reported, the final conclusion was microscope is preferred over endoscope using tubular port retractor. Though all my previous speakers may not agree, but this is what is in the literature. So how do you decide if you get a particular patient of intraventricular tumor to what approach has to be done? It should be decided depending on size. If it's less than 3 centimeter, one can do an endoscopic transcortical. But if it's more than 3 centimeter, one has to decide whether to do a microscopic transcortical or a microscopic transcallosal, depending on the size of tumor. But it's not only the size, but also one has to look at the vascularity of the tumor, the consistency, whether it's cystic or solid, and contents of the tumor also play a role. If it's very hard, again, endoscopy probably is difficult. So what we follow, our protocol is, if you have a tumor which is less than 2 to 3 centimeter, we do an endoscopic. But if it's more than 3, we do a microscopic, either a transcallosal or transcortical, depending on, again, the MRI finding. If there is CSF cleft all around the tumor in the ventricle, then we go for a transcallosal. But if the tumor is adherent to one of the walls, so we don't have a CSF cleft all around, then we do a transcortical, as many times they are attached to the lateral wall of ventricle. And if you do transcallosal, we might leave a tumor or it may not be seen, the attachment to the lateral wall of the ventricle. So we prefer a transcortical in these cases. I'll show an example of each one. Now this case, which this child, a 4-year-old child who presented with raised ICP with multiple spots in all over the body, and this was the scan, which is suggestive of a subependymal giant cell astrocytoma. We discussed a lot on using the syringes, and because it's sharp, and using the silicone tube which is soft. What we do is you just take this is a brain cannula and a glove which is cut, the digit is cut and then used as a distension. So we use this, create the tract, and over this one can railroad either either the silicone tube or the syringe, which turns out to be a little less traumatic than the presently described technique. And even if you do not use a syringe or something, because there is a tract, and if you use the irrigation endoscope, the irrigation is open, the water jet itself opens up the tract while putting the endoscope. I couldn't show the video. Next time I can show the video how the water jet creates the tract, what is created. So this was a tumor less than 2 centimeter, and the technique has already been described to identify the pedicle of the tumor, coagulate the pedicle, and then and after coagulation, then detach it, and the tumor is removed as a single piece. Now, this is the second case. This is a 15-year-old male child with headache, vomiting, and drowsiness with 1 episode of seizure. And this was the scan. And here we find that there is CSF cleft all around. So, and it's more than 3 centimeters. So we did a transcallosal approach. And this is the video, the standard. I don't have to. I do not want to go through the whole video, but the incision, the craniotomy, is not so big. It's not 3 to 4 centimeter. It may be 4 to 5 centimeter. And this is what the tumor with the QSA decompressed and then removed. And it is much clearer than a endoscopic view because it's a 3-dimensional 3D orientation we have. And all of us are better with microscope than only working with an endoscope or an exoscope. Now, this is a case 3, which a 12-year-old with headache and blurring of vision, and it's a large tumor. But then here the tumor there's no clear-cut cleavage between the lateral wall of ventricle. And though the septum is pushed to the opposite side, but it was adherent. So here we did a transcallosal, but we had to enlarge the corridor by working on either side of the ACA. Normally in transcallosal you go through between the ACAs, but here we worked on either side of ACA. This is the ACA work first started in the interhemispheric and then worked lateral to the ACA to have a good access to the lateral part of the tumor. So here working on both sides of ACA, so that we have a better total excision, and post-ops we do not have surprises of little bit of tumor left along the lateral wall of the ventricle. Fluorescence can be used for intraventricular tumors. This is not with endoscope, this is with microscope. We can see here that the tumor and the normal tissue can be clearly seen. This is what advantage with the microscope over endoscope. But now endoscopes have come with fluorescence also. Now, this is a case where there is no cleft between the lateral ventricle and the tumor. So this is the case where we do a transcortical, not transcallosal. So this is done through again a craniotomy, which means not a 3 centimeter trephine, is a 4 centimeter trephine, but use a standard microscopic technique. We have used a retractor, but one can do with a port also. So we studied in 8 years the number of cases which are done. 198 patients with third and lateral ventricular tumor who underwent surgery in our hospital. Out of that, adults were in 153 and pediatrics were 45. 26% were in the lateral ventricle, 47 in the anterior third, and 26 were in the posterior third ventricle. These are the different pathologies we have operated. But what is the conclusion was, when we had 25% of the cases had an endoscopic approach, 75% of the cases had microscopic approach. Though we think of endoscopic, but still 75% we had to do microscopic approach. And the complication rate or seizure rate was 9% in open microscopic and 7.6 in endoscopic. Hydrocephalus was more in the endoscopic group in our series. intraventricular hemorrhage also was a little higher, though means many of them didn't need treat, at least post-op scans for intraventricular hemorrhage. And so the complication rate at the end, the complication rate was in microscopic was a little higher, 6.7% to endoscopic, almost double. But then one has to also understand that larger tumors were operated with microscope and smaller tumors with endoscope. So one cannot tell that endoscopy is better over microscopy because we had a bias in selection of the number of cases. So as such, intraventricular tumors have a higher complication rate, and both with endoscopic and microscopic. But when we select properly, we can reduce the complication rate either when we use endoscope or microscope. So the take-home message is endoscopic excision when it's less than 2 to 3 centimeter size, and microscopic if it's more than 3. If you have CSF cleft all around, one can do a transcallosal, but the absence of CSF cleft all around probably needs a transcortical approach through a port, either with a microscope or a exoscope. Thank you for your attention.
Thank you, Manas, for this excellent presentation. We have some time for quick questions or comments.
Can I make a couple of comments, Suresh?
Yes, yes, please.
I think, Manas, what I think you have very nicely summarized the proper use of two techniques. My only comment in terms of, we also tried to look at this particular thing in our now about 100 cases done with endoscopic assisted or endoscopic lesions. And two important differences which I find in what you have said, and I just want your comment on that, is that when you say CSF cleft all around, I think what matters in transcallosal approach is that there is a CSF cleft between the top of the ventricle. Rather than other walls, I do not think matters so much. But you need to have some cuff of CSF above the tumor for it to be accessible by transcallosal approach. Unlike transcortical approach, where you can, even if it is sort of jutting against or adherent to a wall. The second thing is, I am a little surprised about the incidence of hemorrhage, because one of the biggest advantage I find of endoscopic approach is that you have a much better control of hemorrhage. And in fact, recently, we have stopped using ventricular drains post-operatively, mainly because you are more confident about your hemostasis following endoscopic surgery. So I would like your comment on that.
My hemorrhage means it's not symptomatic. Post-op scan having blood in that. So not symptomatic, which needed treatment. That is what, because in endoscope, when you operate, there's some blood which goes in the occipital horn and all those means. That is what my commentary is on that, not on that symptomatic hemorrhage, which we
not tumor bed hemorrhage. Okay.
Not tumor bed. Intraventricular hemorrhage is what is. And means, unlike your experience of that, you thought that CSF cleft should be there on the top to go for transcallosal. But then I feel that even if there is no CSF cleft, when you go transcallosal, you are directly on the tumor. But then if the tumor is adherent to the lateral wall, one has to do a lot of retraction to see the attachment and have a total excision. So if you do a transcortical, so you're directly on the attachment, and so you're sure of your extent of excision and hemostasis when you are detaching from the lateral wall. And when you're using endoscope also, you are directly on the attachment. If you do transcallosal, it is difficult to reach that area.
Manas, very good study that you have compared, microscopic versus endoscopic, as well as the midline approaches and the lateral approaches, transcortical and transcallosal. Did you look at the tumor factors in particular, like the vascularity of the tumor, the extension of the tumor on the contralateral side into the third ventricle, as well as the consistency of the tumor, and all these factors? Did you look at that while you're doing this study? Manas?
I think Manas is frozen.
Problem with his connection, it seems he's frozen. So,
think-
Suresh, how do we go about? We have already crossed our time, and
Yes.
I think
and there are at least
of our panelists wanted to showcase this.
I think we have discussed extensively. I think we should skip the case presentations. We have now. I think most of the things.
Yeah, because we are already more than 10 minutes beyond time.
Absolutely right. Yeah. Is Dr. Bharti around? I think I don't see him.
Yes, I am there. Hi.
I think, everybody feels that the time has really, we have crossed 10 minutes beyond our scheduled time. So ideally,
We can have some comments from Bhartiya and comments from Atul that he had joined us, and then you can make the last summary. You and Moody can make the last summary.
So, is it Atul is commenting first?
You start and then we'll call him.
Okay. So, from the first lecture to the end, from the anatomy, Karmakar, because he gave a very good and brief introduction of the anatomy that was very relevant to the other talks of the intraventricular tumor surgery with the endoscope. And I think that my presentation was like cavum septum pellucidum cyst I was to present, but as the time is short, so we skip that. But he gave the idea of the cavum septum pellucidum, the space which obliterates postnatally. But if it persists, then sometimes this may dilate to become a symptomatic cyst. Anyway, that is one point. Then the one point was that the port which is made and the endoscope we use, when we use GAB endoscope, the space created is definitely because of the size is small of the endoscope. And if you use LOTA endoscope, then with that, the size which is made of the track is, I think, fairly what Devpujari also said, that you can negotiate your section or your some instrument through that space, and maybe that you do not need a port through that, so that you can carry on with surgery. That is one point. My question was, when I asked about when you use two ports and you need to have one port for the endoscope and the other port for the instruments, what is the main thing which guides for the site of the second port? And it was that navigation and tractography. They are the tools which guide you for the safe. And but then the question what was in my mind was that, is it that the tumor size does not make any difference, because this is not abdomen as it is said that you can maneuver anything anywhere. So is it not that the tumor size or the location of the tumor itself which will guide the site of the port? That was the main thing, and where you need to make, yes, you take into consideration the tracks, you use navigation, but this location of the tumor and its extension would be guiding factor of the second port to be made. These are my questions. And about the epilepsy, we have already discussed, and the personal experiences we have had. We also had the epilepsy in our personal experience using transcortical approach. And sometimes even when you remove a colloid cyst, sometimes a patient throws so many seizures. I have had 3 cases. They become sometimes sort of intractable, not exactly intractable, but there are many seizures and you have to use multiple anti-epileptic drugs. These are my few comments, maybe.
Thanks. Do you want someone to answer your question? Dr. Bhartiya?
Yeah.
Do you want someone to answer your question?
Yes, I wanted, if Sarath is around, Sarath, can you, or Manas, can you, the second port's location in relation to the tumor size and its extension, is there that any criteria or no criteria?
Having seen previous presentation and talk of Dr. Sufyan, now one thing which definitely guides him is the pedicle. If you have some kind of a vascular pedicle of the tumor, your second port should direct to that, so that you can either clip or coagulate that and then get the lesion out from the second port. But I would welcome other comments.
Yeah, I mean, second port, it depends on the, it's the, means one is vascularity and then is attachment. So
the other case which Sofiano showed was that colloid cyst, where the pedicle was not seen, so he had to do the septostomy and then go from the other side. So the second port was introduced from the other side to remove that colloid cyst safely and completely. So this is the advantage of the second port, and that is how you should look at it.
Atul has some comment.
So I was enjoying the presentations and enjoying this new tool which I don't use. But I have got a big experience with colloid cyst and big experience with intraventricular large tumors. One recent paper of mine which was published this year about 145 cases of large intraventricular tumors, which I recently published just a few months ago. All using transcallosal approach. Colloid cyst, all my cases are transcallosal approach, and I'm absolutely happy and satisfied to an extent that I don't think I need any additional help. My question is, you see, colloid cyst is okay. Colloid cyst, you can use transcortical using endoscope and all those things. Although transcallosal is the most beautiful option for microneurosurgery. My question is to you, Shekhar, and to others on this esteemed panel, and having an experience which is largest in the country and others largest in the world. Large intraventricular tumors are, the tumors in the ventricle become large and they are benign, relatively benign. And if you remove them radically and completely, you almost cure the person. Even ependymomas in the ventricle are more benign than ependymomas anywhere else. Central neurocytomas are almost like benign tumors. Intraventricular meningiomas are benign tumors. So most of the intraventricular tumors, the problem with intraventricular tumors is, other than meningiomas, is they are very heavily vascular, with large veins and large vessels, and they are soft and cystic and necrotic and all those things. My question is, when I use microscope, I have control on my instruments, control. I can move the microscope here and there. I can extend my incision here and there, and I can control bleeding, which can be difficult on occasions. What is your experience on using endoscope, which may be a little bit restrictive in your control of hemorrhage, because the tumors, most of the central neurocytomas are heavily vascular tumors. And they extend here and there. I know you can use your endoscope, go here and there, but the power in controlling and your control of bleeding in such heavy bleeding situation, how much happy you are with the endoscope, I would like to know, because I will not, for large intraventricular tumors, do any other approach other than microneurosurgery. I don't know about other approach that is different, but I want to know the experience as to how you can control hemorrhage, which can be quite profuse in massive intraventricular tumors.
Okay. So let's start with Sarath. Sarath?
When you start with endoscopy.
Yeah, I think Sarath or Manas can probably give a better response.
Yeah, so I totally agree with you. Like, all the end of the discussion, I summarized that large tumors has to be done with microscopy, and nobody promoted to do endoscopic. If anybody, people practice large tumors endoscopic only, but then at the cost of time. They take very long time. They for hemostasis at each level they have to achieve hemostasis and proceed. So it's like what you can do in 1 hour, probably it takes almost 8 to 10 hours to achieve that. If anybody has that patience, I don't have that, so I follow you in that. And I totally agree with you that anything, even in the literature says anything more than 3 centimeter, using microscope or using endoscope as an exoscope. It's not an endoscopic. So we are just, because we are confusing exoscope and endoscope. Exoscope is like microscope. So everybody agrees with you. So there's no controversy.
Yeah, Atul, very nice comment you have made. Once we start with an exoscope or endoscope, it doesn't mean that you continue to struggle when there is a problem. I mean, we should be ready to switch over at any point of time. There is no hard and fast rule that you need to continue with that. As was discussed in the previous times, is the size of the tumor, vascularity of the tumor, your comfort, your time taken, all that can be considered to switch over to whichever technique you are comfortable. Ultimately, the quicker and the safer the surgery is better. So that's what it is. Now, having said that, one great advantage of this is in microscope, you end up doing a little larger flaps conventionally, which of course with navigation, we are trying to reduce that size of the flaps. When you do with endoscopy, with a small cortical incision, if there is a problem with the bleeding, you switch over to microscope, you will be able to handle the entire tumor with the same incision. So you don't need to expand the craniotomy or corticectomy. That's an advantage we have seen, that with the same incision, put a retractor in and you can get into, transform that into a microscopic technique.
Can I say
I think
something?
Dr. Yadav has extensive experience with endoscopic surgery. Let him have a comment, and then Moody, please.
I can never contradict Professor Atul Goyal, sir. I know what problem I can have, but still, anything for me, endoscope now, see, you have to differentiate between pure endoscopic, means channel endoscopy, versus port.
Correct.
So for me, endoscopy and microsurgery is same. I mean, but it has come after 15 years of endoscopic surgery. So it's not same for everyone. I take out the large tumor using endoscope, and control of bleeding with endoscope is not a problem when you use air medium. When you use liquid medium, then the whole thing becomes blurred. So this is one thing. And the other advantage, especially in any parenchymal tumor, you just push in the tubular retractor little bit inside, and this thing stops. So I think it is a question of experience, but initially in your learning curve, and if you use a channel endoscopy, then a smaller tumor should be operated and less vascular should be operated with the endoscope. But with experience and using a tubular retractor, there is no difference between endoscope and microscope. Everything can be done. Whatever is possible with microscope can also be done with endoscope, but you need, I think, the experience.
So when you use the port, I mean, the channel endoscope is really challenging. But when you use the port, you are basically using the same microsurgical techniques, using bimanual microsurgical techniques. So there is not much of difference between using endoscope or microscope. Yes, channel endoscopy is really a challenging task, and we have to be very selective what type of.
2D and 3D difference is there.
Yes, but you get you overcome those differences. When you are continuously and repeatedly doing that kind of surgery, it doesn't matter actually. But yes, you can use the microscope also. This is my view on this.
Final comments, Moody?
Yes, I think it's been a fascinating afternoon. It's really, you've done, the conference has done justice to the fact that it was under the banner of the WFNS, and I really thank Chandrasekhar for having thought of this to be under the banner of the WFNS. And I think the lectures and the discussions have been exceedingly valuable, I'm sure, to the young neurosurgeons and to those who want to aspire. The focus really needs to shift away from describing this as a technologically driven approaches. What is best for the patient is what we should focus on. And that's why, and Chandra and I have had discussions about this, when the IFNE was formed, the International Federation for Neuroendoscopy, and you wonder whether there'd be an international federation for cavitrons and international federations for microscopes. Really, we need to redirect our focus, as Atul has mentioned, and Manas has so beautifully described, comparing the endoscope versus the microsurgical and given guidelines, that what is most appropriate, safest for the patient is what we need to use. And we should become familiar with the various tools and how to use them, and not become married to one particular tool and then say, this is the way to do this. Really, I think what this conference has really highlighted is that we must have an open mind, must broaden our horizons, but be prepared to use the technology in the most suitable way for the need and the safety of our patients. So thank you very much. It's been an enlightening and wonderful afternoon. Thank you.
Thank you very much, Moody, for giving your thoughts about it. And in the end, is there anybody else wants to make any comment before I conclude this webinar? Yes, Manas, please go ahead.
And I'd just like to thank WFNS Chairman Professor Dev Pujari and Professor Qureshi for participating with the Neuroendoscopic Society of India. And I request that we have similar meetings in this year again.
Thank you.
We will find another controversial topic to do this, I suppose.
All right. So in the end, it is my pleasure to really close this session, and with the thanks to everybody, all speakers, all panelists who really contributed a lot, making this webinar something useful and very educative. And in the end, thanks to Professor Atul Goel for his inputs to this conference. Thank you very much, all of you, and good night. Thank you.
Good night.